जिसको बोल दो पानी दे देगी। नीला को बोलो।
Sir, we are in live. Good to go.
Welcome to this amazing program which we have today, which is an online certification program organized by the American Center of Reproductive Medicine, Cleveland Clinic. And this is a program which is based on evidence-based nutraceuticals in male and female infertility. And why it becomes important, I'll just share something with you. This pandemic had made me eat medicines like zinc, vitamin C, which my dad, when I was young, always used to tell me on the breakfast table, eat these tablets, but I never used to. But now I have realized that nutraceuticals is going to be the next area of preventive medicine, which is going to be fantastic. And who else could we have for this but two of the top authorities of the world and people who have published, written, taught, and had an amazing life. And in this certification program, we have two of the top people for male as well as female infertility who are going to unveil and unravel the enigma known as nutraceuticals. But before I start, there is something which I had always wondered and always thought about, that how come Dr. Botros, born in Egypt, and Dr. Ashok Agrawal, of course, born in India, have gone to the top places in the world and pinnacled over there, that only comes from one thing, which all of us doctors have, even you have, I have, everybody has, love for medicine. And on this, there is something very beautiful which I'd like to share with you. एक बुल्ले शाह का बड़ा खूबसूरत कलाम है, सिर्फ उसकी 2 लाइन गाऊंगा, लेकिन आप समझेंगे कि कितना रूहानी और कितना गहरा है। कि तू माने या ना माने दिलदारा, आसानी तेनू रब मानिया। तो बुल्ले शाह कहते हैं कि whether you believe or not, I consider you my lover, my God. And love over here, of course, is not the traditional lover. It is your passion. And further on, he says something even more beautiful. तो बुल्ले शाह कहते हैं कि 10 होड़ केड़ा रब दा दुआरा, 10 होड़ केड़ा रब दा दुआरा, आसानी तेनू रब मानिया। बुल्ले शाह कहते हैं कि I do not know any other door to the way of the Lord but you. And that is what has been the essence of people who have grown, because they have really loved their profession like God. In fact, they have considered it a part of it. Osho says so beautifully that when you work, it is the ultimate form of meditation. And this is the beauty of human life. I had wanted to, in this whole program, apart from introducing, ask a few questions which I never got a chance to ask them, of why are they what they are. And this is the reason I would love to start first with Dr. Ashok Agrawal, and then I'm going to start with Dr. Botros. So I'd like to share my screen for the introduction of Dr. Ashok Agrawal. We all have known Dr. Ashok Agrawal, and he's one person who, not only us, I think the whole community of fertility knows him so well, because he has been one of us who has been there to share so much of knowledge with us. He at the moment is the head of Andrology Center of Cleveland Clinic Foundation, Cleveland, United States. He's the director of the American Center for Reproductive Medicine. He's a professor of surgery urology at the Lerner College of Medicine and Case Western University, staff in urology, OBGY, pathology and immunology at Cleveland Clinic. But you know something interesting about Dr. Agrawal? It is that Dr. Agrawal was originally, and his PhD was from Banaras Hindu University, Varanasi. And from here, he went to the Harvard Medical School. So it's very interesting that he was a part of the alumni and he was a part as an assistant professor in Harvard Medical School. And following his stay in Harvard Medical School, which is also with the Brigham University, and he sent me few photographs, and a few photographs I took out. This is for the dormitory and the hall and the library of the Harvard Medical School. This is the Harvard Medical School, Boston, where he was from 1984 to 1992. And Dr. Agarwal has had a very illustrious career. And in this illustrious career, there is one thing for sure, which all of us need to understand, that a lot of people who are there in Harvard Medical School do not want to leave it. But from there, he moved to the Cleveland Clinic, where he set up one of the biggest research centers for andrology. And of course, this has been the mentor of Dr. Ashok Agarwal in Cleveland Clinic, Dr. Anthony Thomas. Dr. Agarwal has been a person who has been at the top level of academic pursuance and academics. So a few of the top people in the world have always been there whom he has worked with. This is the prize which he received, and this is the prize which he received as the 2018 Best Andrologist of the World from ASRM. Dr. Ashok Agarwal has written, numerous books. He has written so many books that I honestly do not have a count of them. But I was trying to actually take out, so I found out that he has about 800 scientific papers and review articles in peer-reviewed scientific journals, has authored about 225 book chapters, and has presented about 830 papers nationally and internationally. He is the editor of about 42 textbooks. He on Scopus is 102. And the interesting thing is, something about him is he has trained over 1,000 specialists all over the world from 55 countries. So, Dr. Agarwal, thank you very much for being over here with us. And we would love to have you for knowing the nutraceuticals and everything about the nutraceuticals. But before this, there is one thing which I would like to know. There are a few questions which I have to ask you personally, which I would, if you permit, ask you. I'll just take a minute. So there are a few things which I have always wanted to ask you, though I have known you for some time, but I had always wanted to ask you. And one of the questions which I have asked you, how was your time in Banaras? And why did you leave Varanasi? This is a question I really would like to know about.
Namaskar, Dr. Sunil. Congratulations on a beautiful program that you are hosting. Namaskar and good evening to everyone, to all the friends and colleagues who are watching and listening to this program. Thank you very much for the opportunity to be part of this very interesting program. I think my time in Banaras was the longest of part of my life. I was born in Lucknow, and my parents were there. We lived there for my early part of my middle school, studied there in Mahanagar Boys High School, and then moved to Banaras. My father, who was a professor at Lucknow University, received a promotion to join the Banaras Hindu University. And he joined as associate professor at that time in the Department of Chemistry. So Banaras was a, a completely different experience for me coming from Lucknow. And as a child, I was still young. I think I moved when I completed grade 8 from Lucknow. So it was quite a bit of turmoil in my life. Um, and it was a very different city, different culture, and everything about Banaras was different than what I was used to. And of course, losing all your friends, your uh, favorite environment. It was a difficult experience in the beginning.
No, I know. But one question which I have always wanted to ask you, Dr. Agrawal, is what made you leave Banaras and how come you reached Harvard?
Well, I finished my doctorate, and just around that time, I was aware of a fellowship from the Rockefeller Foundation, which some of my senior colleague had received. And this was a fellowship which was for advanced studies in reproductive biology that was offered. And it was a worldwide experience, a worldwide competition. So I had to apply. I decided to apply for it and said that let me try to see if what will happen. And I also had to select where I will be working if I get a chance to receive this scholarship. So I opted for the person at Harvard Medical School. Her name was Dr. Anita Hoffer. She was a professor there. And I just forgot about it. I think it was something which was really um, something that I didn't feel that I had the qualifications or I'll be ever be selected. A long story short, I got the invitation from Rockefeller. I also got accepted through Harvard. And I made my trip with the intent that I wanted to learn as much as I can in the field of reproductive medicine and go to this beautiful country and see the new culture and new life there and broaden my horizon. So those were probably what was there behind my decision to do. And I think this was something that many people were doing. Once you do your PhD, you look for an opportunity to go and learn some advanced work. And then if you would like to return, you can return after at least 2 or 3 years.
But from going from Banaras to the Harvard Medical School, it must have been some experience and it must have been something, some hardships, some turning points in Harvard which have made you what you are. So, what has it been? Just share the deepest portion of the areas which would be really interesting for us.
Um, it was a amazing experience, Sunil. I think um, I was both scared and excited at the same time. Scared because of the things that I didn't know. I landed in Boston in the summer of 1984. I remember in the end of June. And I remember some of the things that I wanted to share is that one of the things that I remember is I was hosted in the Vanderbilt Hall, which you showed the picture. It's a beautiful building, which is a dormitory for medical students and just close to the main campus of Harvard Medical School on Boston side. And coming from India, coming from Banaras, I was pretty much a very unsophisticated person and had not lived outside of my home all my life. So when I landed there, I was given a room there. My professor said that this is where you will be living until you find your own housing, and for at least a month or two you can live, and the students are on holidays, so only few students are there. And one day, I mean, very soon, I went to take a shower, and I had, back in India, I mean, I think at that time, I'm talking about 35, 40 years ago, we will not, take off our underclothes, or we will just take the shower with that. It was very unusual to be completely stripped off. And I'm taking the shower, and there was barely few curtains. I mean, it's like several shower stalls and bathrooms, and then toilets in the same area. It's a common area. And while I'm taking shower, I just wrapped myself in a curtain. As I'm coming out, I saw a couple of girls going inside and using the same bathroom, and I just froze. I said, where have I entered? There must be something wrong. And I just could not believe that it was a common co-sex area where the girls and boys were sharing the same facilities. So I was completely petrified. And I said, no way I'm going to use this bathroom again. So it was quite a scary time. I had to use the bathroom when nobody was. And so this was kind of the first experience of my life. Then I think working there, coming from India, coming from Banaras at the time when we didn't even have the computers. We had no computer, we had no television, nothing. And I landed there in Harvard. They had these huge, big bulky computers, and everyone is using those computers. I had no idea. I've never known what is a computer, how does it look. I think we were using the typewriter and things like that. It was quite a bit of a challenge to see how to use these devices and equipment and the entire culture. I mean, I'm there. I remember just a few incidents. Going to a restaurant there, it's a Delhi place, which I used to by myself to buy lunch. I mean, I have to eat something and try to see what is there. So I used to go to this place, and the first time I went, and the guy there, I mean, who's selling these very good looking, I mean, sandwiches, he said, here to go, here to go. I said, what the hell are you saying? I mean, I'm just standing there petrified as to what is this guy asking me? And I'm just pointing, give me this, give me. And a lot of people are standing behind me. And he keep on, I mean, in a Bostonian accent, here to go. I say, I don't know what you are saying. Then the guy behind me said, well, he's asking you for here or to go. Said, okay, that is something I have to learn. So I said, okay, just give it to me something and I'll take it. So a lot of experience and memories. I can tell you it was, it has to be, you have to learn very fast. It was very tough learning there, the things in the research. My professor was very hard and very tough, sweet, but also very demanding. And when the work comes on projects and grants, she will, expect that you work quite late. And one time I'm working and trying to leave, I think after 9 o'clock, and she said, well, where are you going? I said, they're going back home to rest. So, well, the postdocs are supposed to work all night here. You have to work. I mean, it was not unusual to come at 2 o'clock, 3 o'clock in the morning and go home after finishing your research or articles. So it was a very difficult experience, but a fun experience, I will say, because I felt that I didn't know anything at all. I didn't know any type of equipment. I didn't know any of the projects that they are doing. I didn't know about the culture. I didn't know the language, even though we say that we know English, but the way things were so different. And at time, I decided that, there is no choice. I must learn, and I need to learn fast. And that's how it was. It was
But after being in Harvard for so long, you getting a assistant professor job in Harvard, and being also in Brigham Women's Hospital. How come you went to Cleveland? A lot of people do not never leave Harvard. Why did you go to Cleveland Clinic?
That is, I went there, I think, in the beginning when the position was advertised just to have fun. They were paying everything. And I just threw in my application and didn't think much about it. I said, well, I was called and they were, paying for your travel, your stay and everything. I said, well, I'll just go and take a look. I spoke to my professor, and Jerry Ritchie was the chair of urology at Harvard, and Kevin Laughlin was my immediate professor. He said that, Cleveland is just, you will go back, you will go and have fun and come back. Nobody wants to go to Cleveland. So I said, it's fine. So I think the journey to Cleveland was just an interesting one. I met some very, very good people. The chairman, Andy Novick, my immediate boss later, Tony Thomas, they were really loving and caring people. And they really started liking the things that I had in mind. It was an opportunity to start everything from the scratch and really test everything that I had learned and become independent. And we had discussions and discussion. I went 8 times from Harvard to meet them, to discuss and learn about the program. And ultimately, I decided this is the opportunity for me of a lifetime. And all the resources, all the facilities that they were providing were just unique for me to really do something on my own without somebody, trying to teach me and tell me and guide me and hold my hands.
Dr. Agrawal, I'd like to ask you 3 questions, and I'd like the answers quick without your thinking. And they're, they're impromptu questions to you. Number 1, what excites you?
What excites me, I think, are the challenges in life. I like more things which are more difficult. And, and I think I really like to do things which are something which will have a very large impact, not just things which have an impact locally, but I want to think about things which can influence the things around the world. And it's just the way that I think.
Yeah. And what is your philosophy in life?
I think the philosophy is that life is a gift from God. And I believe He has given us a life of a human being. And as we say in our Hindu scripture, there are 84 million living species that are there. We are so fortunate. I am very fortunate to be born as a human being. I should not waste it. I must do something good with it.
Beautiful. What annoys you?
I really get pissed by somebody saying, no, you cannot do it. I think that just turns me off. It makes me mad. And I definitely want to do that. Not that I will succeed, but I just cannot tolerate somebody telling you cannot do it.
And I'm going to ask you the last question, which I want to ask you. And that is, what is your secret of success?
The secret is in everyone's heart. There is nothing very unique about what I think. There are 7 or 8 things that I kind of use as the guiding principle in my life. I will say that I like to work hard, that there is no tomorrow, and without the focus on the outcome. I want to always keep my words. And this is very important to me, that if I tell something to somebody, I must do it. I just don't feel giving or telling somebody and raising false hope is something that I want to do. I want to be innovative in finding solutions to a problem, looking for an out of the box type of solution. And more importantly, once I feel that I have reached a target, I don't want to just um, gloat over it and think and admire it. I just move forward. I think there are so many in my feeling mountains that you need to climb, and you climb one, that's great, you learn, move on, and always do the things where you can exceed the expectations and make quality as the number one part of your life. Never turn down an opportunity without thinking it very thoroughly, because that opportunity may never come back to you. So these are some
Wow.
of the things which are important to me.
Wow, this is fantastic. It is just like Richard Branson of the Virgin Airlines said, sir, he said that if I am offered a seat in a rocket ship, I will not ask why, I will sit into it. So this is beautiful. Thank you very much. I won't take more time because I'm really, thank you very much for giving us so many insights into your life, which would be inspirational for so many of us. I would just like to ask you that the stage is yours, and I myself am waiting for this presentation of yours. Please, sir.
Thank you very much. Let me share my screen. Okay. Okay. Good evening, everyone, again. And thank you very much, Sunil, for this impromptu interview, which where you got me. I think on many things, I just kind of by nature a shy person. I'm an introvert. I'm not as good as some of your past interviewee that you interviewed. So I'm going to be talking about nutraceuticals, and this is one of the topics of our presentation today, and discuss some of the issues here in terms of the rise in male infertility, what is the current technology, idiopathic male infertility, male oxidative stress infertility, antioxidants, etc. So if you look at the causes of male infertility, the three main causes are varicocele, unexplained, idiopathic male infertility. There are many causes which are other causes, as you can see, they are genetic, they are hormonal, lifestyle, etc., which are a significant part of causes. There are so many reasons which are driving this increase in male infertility, and this is a global phenomena and something which is driven by not only the traditional causes of male infertility, which we understand, but a number of issues related to lifestyle, related to occupation, related to our changes that we are seeing in our culture, related to environment. So some of the very important changes that are happening are due to people, men waiting, just like the females, for a very old age. I mean, I will not say old, but advanced age. And it is not uncommon for men to not marry until the ages of late 30s, 45, 50. So between 35 and 45 is an age which among the men is not looked down. Earlier, an age in higher, maybe mid 20s and late 20s was kind of a common thing for boys to get married. But that's not the case. And I think the same thing goes on the female side. It's just a lot of societal changes, a lot of cultural changes, which are driving these changes of late marriages. And then there is the overall decline in semen quality. There are hundreds of studies which are showing that the semen quality, which is sperm count, sperm motility, sperm morphology, they are all declining. And they are declining in different parts of the world, not only in the Western part or in the Asia or Africa. And there are studies which have shown, meta-analysis, which have shown that the decrease in the last 50, 60 years is as much as 60% of what was the values of these parameters before. And then there is the explosion of sexually transmitted diseases in both men and women of young reproductive age. I mean, whether you take gonorrhea, whether you take herpes, whether chlamydia, all of these diseases, and they really affect the reproductive activity of both male and female. Then environmental causes, all of these various emissions from air or various types of pesticides, halates, endocrine disruptors, lifestyle factor. I mean, sedentary lifestyle is because not only of the pandemic, but even before, the lifestyle has become sedentary. We are no longer going in the park, playing and going and walking on the streets. People feel more comfortable watching a serial in the evening, sitting with the family and doing the things which really is become very, very common. Very few people in the United States, at least, you will never see anybody on the street. There is nobody walking and talking to the neighbors or anything, and there is nobody playing out there. So the thing is that it is leading to a sedentary lifestyle. There is an increase in the obesity. There are a lot of use of things like cell phone. There is a lot of stress, not only because of the pandemic, but otherwise, the use of alcohol, smoking, all kinds of poor diet, traditional factors like diabetes, erectile dysfunction. All of these things are driving the cases of male infertility around the world. And many of these cases are correctable. There are medical treatments that are available. There are surgical treatments that are there. And then there are lifestyle changes that can be done. But we want to talk about idiopathic male infertility, as I showed on my beginning slide in the pie diagram. The incidence of idiopathic male infertility can be considered as much between 30 to 50% of all causes of male infertility. And here we have no idea as to what exactly are going on. That is, idiopathic means any disease or condition which arises spontaneously for which the cause is not known. But to define an idiopathic male infertility, there are three things: altered semen characteristic, poor semen characteristic, either count, motility, or morphology, with or without abnormal oxidative stress or sperm DNA fragmentation, and the absence of female factor infertility. This is the group of patient, and it's a sizable group of patient because we are talking about anywhere between 30 to 50% of all cases of male infertility which fall into this category of them. There is not a whole lot of things that are available for this etiology of patients. With idiopathic male infertility, there are many empirical medical treatments that are available. There are hormones, there are Clomid, anastrozole, there are androgen, there are aromatase inhibitors. There are things which are available, but they are not really approved. They are not. There are no strong studies supporting their use. The number of studies are small, and the effects are not very well documented. Then there are issues. There are improvements with changes in lifestyle, advising the patient about all these smoking and alcohol, and then possible combining with the antioxidant and ART, are typically IVF and ICSI. So there's a mixed bag of things. Try this, try that, try this, and sometimes some things work, sometimes something don't. But the majority of these patients just go from one to another, and they lose a lot of time. They get a lot of frustration. They just are the most unhappiest patients that are out there. So if you look at the global incidence of male infertility, there are approximately 200 million infertile couples. And if you look at the strict definition of infertility, about 50% are due to the female factor, 30% are due to the both male and female, and then 20% due to the male factor, or it could be 30 and 20. But overall, male factor occupies about 50% of all cases of male infertility. And if you look at the right side of the flow diagram, below the known causes, which is the idiopathic cases, it's almost 50 million. And in these, oxidative stress is involved in about 80% of these patients have high amount of oxidative stress. And this condition is we call as MOSI, or male oxidative stress infertility. And this is affecting approximately 40 million young men who are married around the world. So let's talk about what is the concept of male oxidative stress infertility, or MOSI, which was coined by us in a landmark publication last year. So here, if you look, the oxidative stress is a phenomena, which is a biochemical phenomena, which occurs in all aerobic cells. And it has a dual role. In very small quantities, these free radicals, which are produced by either abnormal sperm or leukocytes, have beneficial effects on spermatozoa, which are important for preparing the spermatozoa for the process of for fertilization. And these can be listed on the left side. But if they are overproduced, if there is an imbalance between the amount of oxidant and antioxidant, it causes pathological effect, leading to breakdown of lipid membranes, which are in the spermatozoa cell membranes, are rich in polyunsaturated fatty acid, leading to protein, DNA, and all kinds of changes, leading to cell death. And important thing is that about 30 to 80% of infertile men have elevated or high levels of free radicals or oxidative stress, which is a potentially treatable condition. So last year, we had a publication where we had 90 authors or specialists from 6 continents, 26 countries who joined to develop this terminology and for male oxidative stress infertility, and it was published for the management of idiopathic male infertility. So to look at this condition of MOSI, there is really no consensus on how to measure oxidative stress or a diagnostic terminology. We, for the first time, proposed the term MOSI. It is a novel descriptor for infertile men with abnormal semen characteristics and oxidative stress, which was previously mischaracterized as idiopathic. The diagnosis of MOSI is fairly simple. There is a device which is available from last 4 or 5 years. It is called Myoxis, which allows a rapid measurement of oxidant and antioxidant in a seminal fluid. And the levels of this have been already characterized in terms of its cutoff value. And it's very simple to do. It takes less than 3 or 4 minutes. It's simple, inexpensive, well-characterized. Multi-center studies on more than 2,000 patients have been conducted. And the results are highly reliable, even more reliable than the semen parameters, which have been characterized by WHO in terms of their normal or abnormal values. So we had the test name patented or trademarked last year. And we started offering this test at Cleveland Clinic in our lab. So the ORP levels have been reported, or the oxidation reduction potential, which is a marker of oxidative stress, is highly correlated with abnormal count motility of the spermatozoa and normal morphology. So you can see, and we develop on the right side two diagrams, one showing the cutoff value of 1.34 millivolts per million sperm per ml, which was developed by taking a group of about 2,000 men. And on the bottom right, it shows the levels, the ORP levels are highly different in normozoospermic men as well as non-normozoospermic in almost 4,000 patients that were tested. So the test is very simple to do. It can be done on fresh semen. It can be done in frozen semen. It can be done after several hours. It is highly reproducible over and over again, and it takes few minutes. So I think all the constraints of measuring oxidative stress as a diagnostic test has been overcome in this revolutionary test after many, many decades. So we have started offering this test. And not only that, we have a flow diagram here, which we published in our paper, which demonstrates after you do a semen analysis, you do a oxidative stress evaluation, and if the value of ORP is more than 1.34, then it demonstrates that there is oxidative stress. And then there are several different directions that you can evaluate the patient. If they don't have any other kind of condition like infection or lifestyle issue or varicocele, they can go on antioxidant and retest it after 3 to 6 months. If they have infection, then they can be treated with antioxidant and antibiotics and anti-inflammatory and retested for MOSI. Lifestyle, they can be counseled and retested. Varicocele, they can be operated and retested. So we created a very clear-cut direction how to approach these patients which were lumped as idiopathic and just going from one treatment to another and not benefiting at all. But the central issue with these patients, almost 80% of them, is a elevated oxidative stress. So what are the clinical guidelines? MOSI should be suspected in infertile men with abnormal semen characteristics, and these were wrongly characterized as idiopathic with no underlying endocrine, genetic, or anatomical reasons. And these men can be offered testing for oxidative stress to really diagnose their condition. So let's discuss about the role of nutraceuticals in male infertility. And I wanted to show several double-blind placebo-controlled trials that have been published in the literature. This is a big, I think, complaint from many of the clinicians and authors that there are not many double-blind placebo-controlled trials which demonstrate the efficacy of nutraceuticals for male infertility. I think that type of statements are bogus because there are plenty of such studies. One has to just look at the literature and read it. There are 4 here by Belarcia, by Ganan, by Hegg, Hyland, by Stenquist, and you look, they have used different combinations of antioxidants, and mostly they have given for either 3 or 6 months in different set of patients with idiopathic infertility. And on the very bottom, you can see there are improvement in most of the semen parameters, some even showing higher pregnancy rate. But this is another group of double-blind controlled trial which have been published. So again, showing various improvement in products which are a combination of antioxidant products and given for up to 6 months in patients with oligoasthenoteratozoospermia or idiopathic infertility. So my purpose in demonstrating these slides is to illustrate the point that the claim that the double-blind placebo-controlled studies are not available, that there is a need for double-blind placebo-controlled studies as an excuse not to prescribe or recommend or tell the patient the choice that they can try antioxidant when they have this particular condition which we are discussing here, not for every single patient. I believe that those claims are bogus. So let's talk about one of that bogus claim, which was published in Infertility Sterility in a very big trial called MOXIE trial. The authors mostly from the United States, but lacked any kind of urologist or andrologist as part of this team of authors. And they did a double-blind placebo-controlled study using vitamin C, selenium, L-carnitine, zinc, folic acid, and lycopene. And they looked for semen parameters, sperm DNA fragmentation, and live birth rate, but they failed to find any improvement. And as we looked at this, this study was sponsored by NIH. They spent millions of dollars in conducting this study. When other investigators started looking at the data of the study, they found so many glaring problems with this study. And those were published in some very prestigious journal. The one I have here is from Dr. Ramasamy, which was published in European Urology, which is a very high impact journal, demonstrating various deficiencies and shortcomings of study design. They only looked at single semen sample, even knowing that a standard evaluation of an infertile man requires the same man at least providing 2 semen samples over a course of 3 to 6 months, which is a standard part. They also had very inadequate subjects with abnormal motility, which is the starting point was many of the patients had normal motility. The placebo group of this study showed significant improvement in all their semen parameters. They showed significant decrease in sperm DNA fragmentation after 3 months, which is contrary to what you will believe should happen because they are all normal. So this illustrates, among many other things, the weakness of this study. It was poorly planned, poorly designed, and it was no surprise that they failed to find any kind of benefits because the patients which were selected were not really selected carefully. They had no etiology of oxidative stress. They were not idiopathic male infertility patients. So the likelihood of those patients benefiting is very small. So we got very interested in looking at this particular question about antioxidant and how they are really helping from a global level, from all the literature which has been published, to see if we can formulate global guidelines based on very strict systematic review, which is the second highest level of evidence after meta-analysis. And we conducted this study, which has just been completed by our group of investigators. We have almost 20 investigators who are part of this study. And using PRISMA guidelines, looking at all the literature throughout, which is published. And we then conducted a quality analysis of these studies by using various evaluation tools such as Cambridge Quality Checklist, Cochrane Risk of Bias, CONSORT Guideline, and JADAD score to group the studies that are published are selected by us into both low and high quality studies. And these results are amazing. These are cumulative results from our study, which demonstrate that of all the studies, there is a significant improvement reporting in all the semen parameters, almost up to 90%. And the orange bars show improvement in sperm function in all infertile men. Same thing when we are looking at patients with abnormal semen quality, improvements reported in the studies goes over 90%. When we are looking at studies which are targeted towards patients with idiopathic male infertility, almost every study demonstrates significant improvement. So the whole concept of that there are not many studies demonstrating improvement in semen parameters or improvement in sperm function parameters is just bogus. The indications to treat the patient with antioxidant, and these are some of the conditions where treatment with antioxidant will be considered reasonable. Repeated failure, varicocele, older men, infection, smoking, idiopathic, recurrent, spontaneous abortion. So these are some of the compounds for male infertility treatment which have been recommended to provide the best type of effects: vitamin E, vitamin C, L-carnitine, N-acetylcysteine, coenzyme Q10, zinc, selenium, folic acid, and lycopene. And their recommended daily allowance has been already provided through NIH, and which is being given here in this table. So those products which contain the right quantities of these compounds in their formulation should provide good results in the type of patient that we are talking about, those which also test positive for oxidative stress. The beneficial effects of these antioxidants have been described in a large number of studies where we know that some of these products like vitamin C, vitamin E improve the sperm concentration. Astaxanthin has been described to provide improvement in capacitation. L-carnitine improves the motility. Acetylcarnitine as well in correct dosage. Similarly, folic acid reduces the sperm chromatin damage. And lycopene reduces the lipid peroxidation and sperm DNA damage. So there is a lot of studies which have looked at the actual effects of these ingredients and have provided scientific basis for individual ingredients that go into the formulation. We have conducted some clinical trial of our own, which I wanted to share here. This is a clinical trial that was completed last year and published with a group from our collaborator from Hamad in Doha, from Hamad Medical Corporation, Dr. Mohammed Arafa and his team, and where we collaborated as part of this team. So we looked at, this is a prospective clinical trial, which looked at infertile men. Majority of them were idiopathic. And this was a trial where lasted the antioxidant supplementation for at least 3 months. And the ingredients included L-carnitine, coenzyme Q10, vitamin E, lycopene, and acetylcysteine. And they were given before and after the treatment. They were tested for semen analysis and oxidation reduction potential and sperm DNA fragmentation. These are the composition of the supplement. And as I said, as long as main ingredients are present, those type of formulation will be very useful. This particular formulation was from a company called Fair Haven Health. FH Pro for Men is the name of the product. So these are the study criteria. These are the inclusion and criteria. We had majority of the patient were idiopathic, as you can see, and 90% or 91% of them had what we characterized as male oxidative stress infertility. We saw a significant improvement in all semen parameters, whether it is concentration, motility, or progressive motility, which is an important parameter. In terms of motility, we saw a significant concentration as well as progressive motility, as you can see on the bottom. But not only that, we saw a significant improvement of almost as 86% in terms of the normal morphology, reduction in oxidative stress, significant reduction, and significant reduction in sperm DNA fragmentation. We also saw in a short follow-up of the reproductive outcome, a number of pregnancies as both spontaneous and using assisted reproduction. So looking at that, I think the most important thing people ask is the antioxidant will be helpful in terms of reducing the high sperm DNA fragmentation. As you know, sperm DNA fragmentation has been highly correlated with the outcome of assisted reproduction, both in IUI, IVF, and ICSI. And it is a topic of great interest because this is a very important functional characteristic or functional marker of sperm fertility. and it can be measured as you look by a variety of techniques such as tunnel, SCSA, SCD, and COMET. And I think it can also be, there are many ways to treat it. And I think we are going to look at, besides the antioxidant, it can be treated by varicocele, sperm selection techniques, and many other techniques. So some very easy techniques that are available to reduce the sperm DNA fragmentation is just reduced short abstinence using various techniques within the laboratory, which are used by the embryologist to prepare the sperm for ART purposes, have been shown to significantly reduce the amount of sperm DNA fragmentation, magnetic cell separation, PIXI, physiological ICSI, and IMSI. And in very few cases, when there is no improvement in the amount of damage in ejaculated spermatozoa, showing very high amount of sperm DNA fragmentation with repeated failure of IVF and no female factor, retrieving the sperm from the testes has been considered as a method by some of the authors. So the best antioxidant which can reduce high sperm DNA fragmentation are vitamin C, again, E, beta carotene, zinc, selenium, folic acid, vitamin E, vitamin C. So many of these ingredients that you saw in the previous slides. This is another study. This was conducted. This is a clinical trial that we did at Cleveland Clinic. And here, I think the goal was to look at the changes that occur at the molecular level, not just at the microscopic level or the functional parameters such as sperm DNA fragmentation. Here we are looking at the proteins which dictate the function of various sperm properties. So again, it's a study, it's a clinical trial. Patients were given the antioxidant for 6 months. We used the same antioxidant, FH Pro, for men. And we included patients who are oligosospermic, asthenosospermic, or teratosospermic. And the study design included looking at treating the patient for 6 months, and then before and after doing the proteomic analysis using the mass spec spectrophotometry to look at the protein profile, expression of proteins. As you see, there are large number of proteins that we see, more than 2,000 proteins. And we looked at the proteins both before and after the treatment and see how many proteins are unique to the treatment, and then looked at their properties. So we selected 4 of those proteins, and these proteins are here, actually NDOFS, which is responsible for oxidative phosphorylation or oxidative stress, CCT3, which is important for binding of the sperm to the egg, and PRK, one is responsible for sperm motility. So in all of these proteins, we see a significant improvement after the 6 months of antioxidant supplementation, which demonstrate that there is a significant beneficial effect on sperm function protein associated with fertility at molecular level. So all of these proteins that are being influenced are responsible for functions that are expressed in terms of increased binding of the sperm to the egg, increased sperm motility, or reduction in oxidative stress, which really is responsible for sperm DNA fragmentation and poor fertility. So looking at the paternal aging, which is another area which is really important in terms of the lifestyle I described about it, the studies have shown that men, as they reach the ages of 40 and above, they have poor semen quality, they have high DNA damage, and they have a lot of epigenetic changes which really impact on the ART outcome. And they really lead into higher number of genetic defects in the offspring that are born. The amount of mutations that are seen, and they are significantly increased with the age of the father. So if you look at the left side of the bar diagram, you can see there is a significant amount of de novo mutations that are occurring, and they increase significantly from early age all the way to the age of 50. And the same thing goes in terms of the graph on the right side. What does it mean? It just shows that there is significant amount of changes that are occurring in the semen. And as shown by studies here by Dr. Don Evanson, that the amount of DNA fragmentation increases significantly after the ages of 40, 45 to going up to 60, 65. So there is a remarkable increase in the amount of sperm DNA fragmentation levels becoming highly abnormal. And I think what is happening is as we are going and using the ART, many of the clinics, many of the people around the world are using ICSI for purposes which it is not intended. We are really, I think, using ICSI in an excessive manner. We are using ICSI, which is really the treatment for severe form of male infertility for conditions which really do not require the use of this very sophisticated procedure. And this particular graph demonstrates that if we continue to use this technique, and as the technique become better over the years, we may see the world population of children who are born as a result of assisted reproduction explode from a very small, like 0.1% of the total population to almost 3 or 4%, almost 400 million in just about 80 years. So this is really, I think, something very, very alarming. And I'll tell you why it is alarming. Because what we saw that the semen quality in children who became adults from fathers who were born as a result of ICSI was compared with children who became adult who were spontaneously conceived. So if you look at this published in Human Reproduction, there is a significant decrease in the semen quality of children who were born 20, 25, 30 years ago as a result of ICSI. Their semen quality is significantly lower. They are already highly abnormal and they will be needing ICSI. And some of you may say, well, this is not a big deal. I mean, ICSI is there and why not? They should get it. Well, there are reasons I think that we should really consider and think about it, because there are so many indications which are showing that excessive use of ART is leading to a variety of conditions and syndrome which are going to show up at different times of our lives. So just from the paternal age, if the men are waiting for too long, there are significant amount of risk to the children who are born. There are many, many syndromes. There is a higher evidence of the effect of age in these children. So if we look at overall statistics here, the number of couples who are infertile is growing all over the world. And the incidence of male factor infertility is growing. It is the number of 93 million is a very conservative number, because very few places really report incidence of male factor infertility. So in our paper that we published several years ago, it was extremely difficult to come up with these numbers because most societies, most cultures don't report male factor infertility. There is no publication to that. So we believe that there is a room, there is a role for antioxidants, and there are many myths which are there against the use of antioxidant. And I wanted to describe them and tell you what is the reality. People say that very few antioxidant trials are published, and that we need a lot more trials, double-blind placebo-controlled trial. But the fact is there are large number of trials which are already published, and many of them are randomized, controlled, blinded or unblinded. And there are a lot of uncontrolled studies. So there is no shortage. You just have to look at the literature and read about it. People said that we need multi-center studies, multi-institutional studies with large sample size. But then antioxidants are not pharmaceutical products. They are not backed or manufactured by large companies with deep pockets. These are products which are not considered as pharmaceutical agents. They are not regulated in the United States by the FDA. And the cost of multi-center studies based on large sample size is just simply unaffordable for most investigators. So to consider that we need large studies with hundreds and hundreds of subjects is just not realistic. And I think it's just an excuse put forward by people who have no interest in considering the use of antioxidant. And that we need placebo-controlled studies. I think, first of all, I think there are many studies which are placebo-controlled. Second, I think to deny the patient a treatment is just not fair. So I think doing a placebo-controlled trial is difficult because you cannot ask the patient to wait for 6 months without any kind of treatment. Then the length of antioxidant treatment in the studies that are done are insufficient. However, the fact is majority, more than 80% of the studies published report a length of treatment of greater than 3 months, which is considered acceptable. And that more rigorous patient selection is needed. Some people say, well, many studies which are published show that the patient with varicocele, abnormal semen quality, patients who have idiopathic male infertility and unexplained male infertility are the suitable candidates for these treatments. Then there are investigators who are asking more studies looking at the effects of combination of antioxidant. And again, there are many studies which have looked at this. So there is no shortage of that as well. Then there are people who are asking for pregnancy and live birth outcome. And then only they will trust the results and efficacy of antioxidant. Then we say, well, this is really a thing which is not based on science, because the treatment or improvement in semen quality or improvement in one gamete is not a guarantee that it will result in pregnancy and live birth. There are two hands are needed to clap. So unless you can rule out every single possibility in the female partner and so many changes that go on during the ART procedure, it's very difficult to really say, or during the natural pregnancy, to say that it is due to the male factor. Then the molecular basis of treatment is not known, but that, again, I think we have a lot of studies looking at the sperm DNA fragmentation. We have many studies looking at the proteomics, which are coming up. So we are really making progress in that direction. So if we summarize what we know at the time in terms of the current technology, ICSI should be reserved as a treatment of choice for severe oligoasthenoteratospermia. There is microTESE for patients with severe obstruction, use of testicular sperm. In few cases, very highly selected cases, where there is very high sperm DNA fragmentation in ejaculated sperm and repeated ART failure. A specific medical therapy is available for infection, for anejaculation, for retrograde ejaculation, for erectile dysfunction. Microsurgery for varicocele repair is a standard of care. Hormonal therapy, which is more empirical, certainly considered a standard for hypogonadotrophic hypogonadism. For many of their hormonal treatments, it depends on physician experience and the patient that they are treating. So this is completely individualized. Medical therapy for MOSI, for patients with male oxidative stress infertility, use of oral antioxidant supplementation, we believe is justified and appropriate. And we need to give the chance to the patients to try natural conception. We really need to allow them to try natural conception before they undergo expensive and invasive procedure of assisted reproduction. I think there is a time, there is a place for the use of the antioxidant in a variety of patients, making sure that they are tested for the oxidative stress, which I believe is an important diagnostic test to confirm that the antioxidant will be helpful, and then provide them for at least 3 months, give them in correct dosage in the type of compounds which have shown in, most benefit, and making sure that these patients are actually following this regimen for at least 3 to 6 months. So I believe that many of these patients will benefit and may be able to complete, may be able to succeed by simply going through the natural conception. And the others can then be suitably treated with ART or other forms of treatment. So thank you very much. This is our group at Cleveland Clinic. Thank you to everyone, and thank you to Sunil. Thank you.
Thank you very much for the elaborate and scientific basis of nutraceuticals. The problem with most of us is that we feel that they are placebos, not realizing that in male infertility, this becomes one of the mainstays in idiopathic infertility, which is nutraceuticals. But male nutraceuticals is still a topic which has been much discussed and has been much elaborated. But the role of nutraceuticals in a woman is something which not many people talk about, because there's so many other things in the armamentarium which people can talk about, number one. Number two, nutraceuticals is not a very big pharma-driven product, because of which a lot of focus is not there on that. But today, just imagine whom we have. Thanks, of course, Dr. Botros for being here, because we have Professor Botros with us. I mean, he has an illustrious career, a career which I would not say that anybody could have, but it's something which very few people in the world could have, especially when somebody who's born in Egypt and reaches the pinnacle and is one person who works with who else but Sir Robert Edwards. So for somebody like him to be with us, I think it is an honor for all of us. Thank you, Dr. Botros, for being here. It's so kind of you. Your volume, your voice, please.
Thank you so much for this wonderful opportunity to share the podium with you, with your extensive scientific efforts, with Dr. Agarwal, a dear friend and the pinnacle of male fertility in the United States. So it's a great pleasure. It's a great honor, as always, to be part of the team and to be part of this scientific contribution this morning.
Thank you very much. I would just give a short introduction of yours, though the introduction runs into about 12 pages, but I have tried to concise it. I've tried to concise it into, I would say, 8 lines. So it's been a tough job for me. So, sir, the first job which you gave me was the making your CV concise. So I'll just start on with this. I'd like to share my screen, please. Dr. Ritz he leads the IVF elite team in Houston and presently, and is a world-renowned fertility specialist and reproductive endocrinologist. He is a pioneer in the field of infertility and reproductive medicine. And before this major, I would say, team which he leads, he was there as the professor and head of reproductive endocrinology and infertility at the University of South Alabama for 25 years, from 1993 to 2019. But something which is most interesting is these are two photographs which all of us know about, Patrick Steptoe and Robert Edwards, and they were the pioneers. But do we know that their team also had a few people who today are running IVF and along with, I would say, the research work all over the world? And these photographs have been kindly provided to me by Dr. Botros. And this is the first picture which was taken of Louis Brown. This is when she was placed on the weighing machine for the first time, and the first IVF baby on a weighing machine. This is the picture of Bourne Hall at the time when Louis Brown was born. And thank you, Dr. Botros, so much for these lovely pictures. And as you can see over here, Professor Bob Edwards with the whole team. And today, the way the picture would look at. Dr. Botros, it is such a pleasure to have you over here because for somebody, yes, sir. So because somebody who was mentored by the Nobel laureate Professor Robert Edwards is there with us. These are the number of books, about 28 textbooks and about 400 publications, which Dr. Botros has done. The interesting thing is that he started his career in the illustrious London and Cambridge. And this was the place where most of the legends were there. And as a foreign medical graduate, to become a senior registrar in Cambridge was unheard of in those days. Uh, Dr. Botros has been a very big author. And apart from that, he has been an early founder member of ISHRI. He's the chairman of ASRM training programs and is the president of Middle East Fertility Society. Sir, welcome on to this beautiful program on nutraceuticals, because nutraceutical is something which we know very little about, especially in women. So from knowing from you, the evidence-based nutraceuticals is going to be amazing. But before you start, I have a few questions for you. These are personal questions, and I'm sure you would answer them to us. And we would like to have a lot of questions, but short, and they need to be something which really inspires us, because that's what you are for. And so the first question which I would like to, I'll just stop my slide sharing. So something which I have always wondered, Egypt and the United States. Uh, how come from Egypt you went to England? And what was Egypt like and what was England like?
Well, I loved Egypt. I was born there and I grew up there. Frankly, some of my happiest years ever has been the medical school. Particularly the first 2 years were fascinating. We had really great professors, phenomenal teachers. I mean, until today, after as many years, different places and so on, I'm still amazed. And I could recall some of the lectures as the first year medical student, the way they were given, the way they were delivered, just amazing people. It's sad that many of those people have passed away before we give them the tremendous honor and credit that is due to them. So Egypt was really a phenomenal place to do the medical school. Cairo University is a world-renowned school. Has been there several centuries. Was started by the British. The medical part of it was started by the British several centuries ago, and I had the great honor and delight that basically almost all my family members have graduated from the same medical school. So my mother, my aunt, my uncle, my sisters, my brothers-in-law, and so on. So almost all of us graduated from the same school. I was the last and the youngest. So to me, it was an aspiration to go to the same place, and I've loved it. I've enjoyed every day there.
There's something which I wanted to know, because it's believed in England, the first job is the most important job. Please tell me something about your first job in England.
Right. So of course, leaving Egypt at a very young age, I left right after the intern year and so on in Cairo. So went to England, and at the time, it was a totally different country as far as international graduates than today. Like today, you walk in London and almost everybody is from a different country. But the time I went, it was basically the complete opposite. It was very difficult to get a residency there. So I did 14 locum jobs. Some of them weekends, some of them 3 days in the middle of the week, to be able to apply and get my first, not my first residency, my first 6 months of residency. And then after that, I am again on my own and reapplying again, but at least to be part of the system that might lead me anyway. So after 14 locums, my late wife was the one that was neat and organized and so forth. So I never typed anything properly. So she typed my CV and she put that I did a job which really was 2 weeks from June 14 to June 28. But she forgot to put the year. So, or maybe she put the year, but they didn't notice it. So they thought I had a year and 14 days in the job. So they put me on, shortlisted me for the interview. Other than that, they would have never shortlisted me because it was a senior resident job. So here it is, this young guy coming in, having basically almost zero experience. I mean, pretending to have any experience, and they coming for an interview for a senior resident job where you cover one of the 2 hospitals on your own. So it's really a big responsibility. And the chairman was one of the greatest mentors I had, and tens of us had. Like Dr. Agarwal has mentored hundreds of scientists in the US. Dr. Dudley Matthews, Mr. Dudley Matthews, as we call in England, Mr. for a senior surgeon, has trained tens of us. So I was among his, later in his career, he was almost 60 at the time, of graduates that he trained. So after interviewing me, he found, I don't know what he found, but he considered me. So he asked me, have you done cesarean sections? So I say no. I mean, you know, I done 4, and the guy before me has done 200. Have you done breech deliveries? I say, well, 5, and the guy before me has done again another 100, 200. So really, in the balance, there was obviously no reason for him to pick me up. So he thought about, and this is the chairman. There are 4 departments, and this is the chairman of all the 4, and the chairman of his own. Beyond the great teacher. So at the end, he said, you know what, I'm happy to offer you the job, but before you say yes or no, go home and think about it, and for over the weekend, and then if you decide to take it, let me know next week and we'll talk again. I said, no, I'm decided. I can start now. So he took me. And he was the most, like it's very rare that somebody says that the first year of your residency, most people are in depression and in exhaustion and so on. I think I was in a constant euphoria. We would have 70 patients in the morning to see. He would see 50. This is the chairman of the whole thing, so that he lets me see 20 because ultrasound was very new at the time. So I wanted to do ultrasound on every patient and measure their, like the baby's head and stomach. And this was very, very new. This was the early 80s. So to allow me to develop my skills, he used to do the burden of the very, shall I say, menial jobs, or the jobs certainly not for the senior chairman. We're not talking about a consultant that's appointed yesterday. This guy is the senior of the 4 consultants we had, and so forth. So it was a phenomenal year. And then he accelerated my career beyond belief after him.
How did you reach? I was reading you were in Cambridge, and you were one of the few foreign graduates ever given a senior registrar job in Cambridge. So just tell us.
Yes.
Yeah. So how did it happen? What is there in you which made everybody crazy?
I think Cambridge was really amazing because, number one, you have to put things into context. So I finished my British the MRCOG pretty early in my career. So I really went there, as I said, and he gave me a senior resident job, and then after that he pushed me to like a registrar, basically doing the duties of a senior registrar. So I finished literally within 30 months, which was less than actually basically the very minimal requirement. So when I was done, I was dying to do reproductive endocrinology and infertility and IVF, and it was very new. So the national health system in England had no IVF, like not today that there is a fellow in every medical school. As a matter of fact, until a few years before I joined, they were very opposed to IVF, not just neutral or few places. They were extremely opposed to. All the top medical schools considered that this is a very kind of, I don't want to say, but they consider that this all is fake, to the point that two of the most famous professors in the history of the United Kingdom have written a book together on infertility just as IVF was starting. And their introduction, they said, and this is a book. We are not talking about a TV interview. He said that that IVF and those things are like dreaming research ideas, but microsurgery is the real thing. Microsurgery is here to stay, and all this IVF will, and the guys that are doing it will come and go. There will never be a time that we treat patients with infertility with IVF. This is like we're talking 81, 82. I started my career there in 84, and then, so when I joined fellowship, my boss at the time for the residency took me aside and said, you're having a great career, but you have to understand that the fellowship is in a private practice setting. So Robert Edwards, the professor of physiology at Cambridge, could not do it at Cambridge. So he's doing it in a private practice, and I'll share with you the details of that. So if you go to the private practice infertility side to do the fellowship, you're out of the national health. And if you left the national health, basically you'll never come again. You leave the government, you left the government. So I said, well, this is really what I want to do. I mean, period. I mean, even if it meant after that I'll go somewhere. I don't know where, but I go somewhere. So I did it. And then very, very fortunate, even before the fellowship was over, which was 2 years at the time. Now it's 3 years, I believe. So like a year and a half, I applied for the job to Cambridge, so university and so forth, as the senior registrar. And my seniors at the job took me aside and said, listen, don't take it personal. You will go. Consider it a training exercise, considering for you a good way to maybe to get experience how this is very stressful jobs and how that you interview and how you answer and so forth. So I said, fine. I mean, I understand. So the two of them have been through 35, 36 interviews over like 7 years and so on, and they were unfortunate. So I went to the interview. I mean, just hoping for the best. I went there, and it was Cambridge University. And a huge hall with a long table. At the head, the professor of the university, and on the right side is the members of the faculty of the university, the professors, associate professors, scientists, deans, and so on. And on the left side is the National Health Service with the consultants, senior consultants, junior consultants, and all the guys that make the decision. Altogether, 12 people. And they have a scheme of questions that they ask you. There were 5 candidates, each was an hour. So needless to say, a very long day. And of course, it was beyond shock that at the end of the interview, not in another week or two and so on, they called me back. And they said, well, the two sides of the committee, the National Health and the university, for one rare occasion, both of them have agreed to offer you the job today, and you can be you can go to Cambridge University magistrate to sign your name as the university lecturer and the senior registrar, which to me was beyond the belief. And really, even the people that interviewed, we took the train back to London. I used to live in London, so we took the train back. And neither me nor them were in belief, because, I mean, it was just, and I was like 29 years, so also the time was, I mean, very, very young for that job. So Cambridge was great, no question about that. And I'm very grateful to them to today that they offered me this opportunity, because the exposure was extraordinary.
Wow. This is beautiful. Tell us something about Sir Robert Edwards. We'd really like to know, when you worked with him, how was he? What kind of a man was he? I mean, these are things we just don't know.
He was a phenomenal man, phenomenal man. One of the best things, so I was saying earlier about giving credit or being grateful to people who've helped us, and many things all of us are short on, is that we do not really thank people enough for what they have done for us. So one good thing is that in 2008, so IVF was the first IVF was Louise Brown, July 25, 1978. So 2008 was 30 years of in vitro fertilization. So we decided, and Bob Edwards was in his early 80s at the time. So like probably 80, 81. So we decided to give him a huge kind of celebration and honor. So we invited literally everybody, that's everybody in the IVF in the world, from Antonio Pellicer to Spain to South Africa to every country in Europe to Germany. I invited all the editors. Of course, he founded Human Reproduction and he founded the European Society. So everything that we're part of today, he started. Not like he thought about, he started the European Society in the early 80s. There was no European Society for like infertility called the ESHRI now. Of course, the world largest meeting, and so on. He started that with just him and 3-4 friends by his inspiration. So we invited him and we honored him, and we did 3 movies about his life. So we did a movie by the editor of Human Reproduction at the time, a German professor, about his pure academic achievements, landmarks of academic achievements and publication achievements, which is beyond the belief. I mean, this alone could take some time. And then I did an hour talk about him as the person, just as the guy who you work with every day. And this was done in the Library of Alexandria. Of course, the Library of Alexandria was the world's first library ever from 3 centuries BC. So to do it there was very, very sentimental.
Oh my God.
And then we got, one of my colleagues from Cairo got in contact with with his wife, with his friends, with his secretaries, and took clips of his life, and we made a video of his life. So he's been an amazing person. And the opposite of what you think. You would think that a guy like that would be a very, and he was at the top of the world. I mean, literally, he was fortunate that he lived long enough, because Steptoe had cancer and died literally within 10 years of the IVF. But Edwards lived. I mean, so he basically, Edward died in 2012. This celebration was 2008. IVF in 2008 was 30 years. In 2010, he got the Nobel Prize, and in 2012, he died. So really, he lived long enough. So basically, every university in the world has given him an honorary PhD or DSc. But the bigger thing about him, his extraordinary support for the junior people. So I was the youngest fellow, the lowest one in the team. And the amount of dedication and sincerity that he deals with you until today is puzzling for me. How do you have somebody that is so dedicated? I always remember we did one of his PhD students, she's the editor of one of the journals in the UK now, name is Geraldine Hartshorn, and another young lady was doing, the other lady was doing a thesis on the immunohistochemistry of the endometrium during different times and different hormones and so on. So we wanted to do pathology, do receptors for estrogen, progesterone, do proteins, placental proteins, assay, and so forth. So I got the clinical material from them, and she did the lab part as part of her PhD. So all the material to be used, like we have to stain the endometrium, this and that, came from his lab, from the physiology lab in Cambridge. So one day he was coming to London, to our center in London, and he brought himself all the stains, carrying them. And again, he was at the time, he was in his early 70s, late 60s. He took his car to the train station in Cambridge, took the train from Cambridge to London, took the underground from the train from Victoria Station to the lab, and then walked about 1.5 miles to the IVF, and then walked 4 stairs. My office, we had the whole building, office was on the 4th floor. And I was seeing patients, it was 4 o'clock, 5 o'clock at the end of the day. So he got so tired after all that, so he sat on the stairs in front of the office. So the medical director at the time was walking up the stairs, so found Professor Edwards sitting at the on the stairs in front of my office. So he told him, Professor Edwards, sir, why don't you come to my office? And so he said, no, I just got tired from 4 flights of stairs. So I sat down to rest a minute, waiting for Peter Risk to finish. So he said, you're waiting for Peter Risk to finish the patients? He called the chief nurse, said, cancel all the patients for me. Let Dr. Risk come right now. And he told him, no, let him finish his patients. We need them for the studies. I mean, that kind of guy, and so on. And I remember the next day, the Minister of Health in the UK came to visit the center, and he had some major disagreements with her before. We met her. He refused to meet her in person. And he was there, and he did not. So this is the kind of guy that if he, if he feels you're contributing, he's beyond supporting. And if you feel that that you're not doing what you're supposed to do, he would be very upfrank.
Wow! This is such a beautiful story which we have just got from you. Wow, this is amazing. But after having had such an illustrious career in the UK, what made you go to the United States?
Well, it has been really my dream to come to the US from the beginning. So when I was a medical student in the 70s, I came and to the University of Tennessee in Knoxville. Knoxville at the time in 79 was a very little town, not like it is today. So it was a very little town and so forth. And then the university found that I'm interested in American, culture and American people and so on. So they arranged for me a trip, 3 days in one city, in one state, to spend it with the families there. Tremendous variety, from a school teacher to a doctor to a Wall Street guy to people doing business in San Francisco, over a month's time, so that I get exposure to the different. And I was amazed by 2 things. I was amazed truly by the American people, and this is not political in any way, but it was just that, the amount, the kindness, the generosity. Here it is, they don't know anything about me. I'm walking into a school teacher's house in Denver, Colorado. She frees Friday, Saturday, Sunday. She takes me downtown. I take some pictures and so on. And until today, I cherish those memories. So from that day, I really wanted to go to the US. Of course, also, it was stunning for me, the nature in the US. I went to the Grand Canyon. I couldn't believe I come from Cairo. So Cairo is a great city, but just a flat city and so forth. So when I saw the Grand Canyon, I couldn't believe that there is anything so beautiful at all. And of course, the West Coast was amazing. And then I went to the East Coast. So I really wanted to come to the US. So when I finished medical school, again, my wife filled in 400 applications for residency in the US, and I studied hard, so I got good grades in the passing exams. So everyone sends me a letter back saying that they are very, very interested in the candidate, but at this point in time, it would not be possible for them to consider me for an interview or shortlist. So I think we applied maybe a couple of hundred residency spots. At the time, this was 1980, it was impossible to get a residency in the state if you're living 10,000 miles away and sending a letter. Before that, in the 60s and 50s, was totally opposite. Dr. Combs, they literally, the positions were very open. So I couldn't get to any of the, I didn't have a chance to apply, not even to opportunity. So I thought, well, I studied the British exam. So I did the surgery, Royal College, and then the medical and the OB-GYN and so forth, and they decided to go to London and so on. And then London was, of course, probably more stimulating than any other city in the world at the time, because you have the 12 medical schools. There is tremendous activity and so forth. And medicine was very different than now. Literally. So there was more and more interest in many things and tremendous support. And then when I finished, one of the fellows, one of the doctors that were working, American doctor, was coming to learn IVF because London was the only place from us in London. So he used to come every 3 months and see what we do. We were the first in the world to do picking the eggs by ultrasound, because before that, step 2 used to do it by laparoscopy. So he used to come and see how do we pick it, and he developed his own thing. So every time he comes, he says, "You must come to the US." So he rekindled that, and from there we started again.
Wow. After coming to the US, I mean, you have lived a beautiful life, but there must have been very tough times which you must have faced.
Was very, very difficult because at the beginning, I came in '93. At the beginning, I went, had some friends at the University of Chicago, and I was offered a great position there. But then, if you come at the time and take a position like that, then you're not like board certified in American board and so forth. So then other friends at the University of Alabama said, "We can help you both ways." So really, I mean, there was a setback in career because I was almost at the very top. I was at the top place, top position, and I could have literally, accepted any position at the time. It was also a great time. I mean, it wasn't just work. I mean, going to work every day was beyond exciting. I mean, we never wanted to leave because every evening we used to look at something and be fascinated that this is what we found. So even if you look at the number of like publications at the time, it's 10 times what we're producing today, not because of anything, because of the.
I'm just interrupting you. Any interesting case? Because we all know that you have done a lot of research work in endometriosis, hyperstimulation, the long protocol originally, as it has been set, was set by your team. So any interesting case which you could just tell us?
Yes, it comes to my mind, one of the turning points in my career. So after I finished the residency and before starting the fellowship, I went to London in a big hospital called Northwick Park. Northwick Park was one of the London top hospitals, and I was on call as the registrar, like chief resident, if you want to say. And one night they called me, they said, well, there is a lady in the emergency room, and her blood pressure is very low, very, very low, 70 or 30 or something like that. Tachycardia, we couldn't even hear the pulse and so on. Tummy distended. She has some diarrhea and so forth. So I said, well, it does sound like it's something cardiology or maybe something medicine, but what does that have to do with the gynecology or the fertility guy? They said, no, she had something called GIFT this week and so on. So of course, I was just reading about GIFT. I haven't started the IVF at the time. So I went to see the lady. The lady was actually of Indian origin. She came from Kenya to London to have GIFT. And she was done GIFT by one of the most eminent physicians and surgeons who until today is one of my best friends in London. Nothing related to our team at all. And then several days later, maybe 5 days later, she collapses at home, and they thought she ate something bad and so on. So she comes in, we check her, and really almost no vital signs. We don't know. So we do a quick abdominal ultrasound, tons of fluid in the abdomen and pelvis. And then she had also like a couple of ovarian, the ovaries were enlarged. She's very, very slim lady, very easy to evaluate. And the ovaries were enlarged, literally watermelon sizes on each side. I mean, there is almost nowhere space for her to breathe. And then her hemoglobin dropped and so forth. So she was bleeding from those ruptured cysts. So we had to stop the bleeding, which was very tricky. And again, I was the chief resident. I thought at the time that I was a reasonable surgeon, a good surgeon. So I took her to the operating room. I called the chairman of Northwick Park at the time was Dr. Ineas Fisher. Was he was general gynecologist, but had a great interest in infertility as well. Was very well known in London at the time, in the 80s. So he comes immediately, and we go to the operating room like 1 a.m, and we stayed operating like 5 until 5 a.m. to try to stop the bleeding she had. Every time we tie a suture, the whole suture comes. So at the end of this, we got it under control after 4 or 5 hours. And he was a very delicate surgeon and a great guy. He looks at me and say, Peter, I guess the message is don't take people like that to the operating room anymore. I mean, he was of course joking. I mean, if we left her, she would have died. If we operated on her, we almost died, And then she stayed 3 weeks in the intensive care. There was no literature. Of course, this was before the internet, but there was no publications. So I went to the Royal Society of Medicine in London. They had a huge library. The library they opened for those big metal things. And I kept looking for some material for me to guide me her treatment. I could hardly find anything. I found an article from Israel from 1978, 10 years before that. So I took the copy, and I made photocopies, and I took it with me to the intensive care. So every day the head guy of the intensive care say, so what is the plan? I said, I have no idea. I called everybody that I knew in London, and nobody knew what to do. And what do? You give them fluid, they make fluid on the lung. You don't stop fluid, they have kidney failure. Every day there is a new problem. So we really, every morning I went there saying, what am I going to do today? With this, I left everything else and focused on her for 3 weeks. After 3 weeks, she recovered. She went home. She delivered the baby early a bit, but she delivered the baby, normal, healthy baby. She had a stroke at the time from the hemoconcentration, and she almost had renal failure. She recovered, and she came back to the same doctor to do the second baby. And I published her in Human Reproduction in 1990 because it was stunning. I mean, it was actually the first. After, like, there were some publications like that from 1967 from Israel, and then nobody ever talks about these topics again. And then we published that in 1990 in Human Reproduction.
Wow, this is interesting. Dr. Peter, I could go on talking to you for the next 2 hours, and I think we'll have another program for that because, wow, you're an amazing storyteller. Thank you very much. I would just like to invite you now to share the stage for nutraceuticals in female infertility. Very little is known to us about it. And in fact, we really do not know what does evidence say. And it would be such a pleasure to have your lecture now.
Thank you.
The stage is yours.
Share the screen. Are we good?
The slideshow, I think we just need to do this. Yes, that's it.
Perfect. So again, it is a great pleasure and a great honor for me to share the podium with Dr. Agarwal, who really pioneered the antioxidants, their evaluation and their management in the male side of infertility. So I will be very much focused today and share with you some of the most recent developments in female infertility regarding antioxidants. So really, antioxidants is been defined very clearly by Dr. Agarwal and his team to be an imbalance between reactive oxygen species and the presence of antioxidants themselves. What really reactive oxygen species are we talking about? We're talking about basically superoxide anions, hydrogen peroxide, and other antioxidants that are there as well. He quite elegantly elaborated to you the exogenous sources, particularly on the male side, when he said, well, I mean, there is some genetic elements, but also there is the exposure to smoking, to alcohol consumption, chemicals, pesticides, and others, and then other things like basically the presence of inflammatory factors and so forth. Could there be psychological elements? Definitely. Could there be impact of age? Definitely. And also dietary deficiencies are very possibly incriminated as well. How do all the things impact the delicate balance between oxidative stress, between antioxidants and ROS? Really, many of them tip the balance. For example, the excessive use of alcohol would decrease the glutathione, increasing BMI would increase the lipid peroxide, and so forth. The presence of course, any smoking, whether firsthand or not, could possibly decrease the actually available nutrients, and also increase the activity of enzymes like catalase and others. Of course, cocaine and marijuana are big problems, both of them in the United States. Particularly cocaine is a huge problem, and marijuana is so prevalent that their impact on basically superoxidation is tremendously harmful in many situations. And we have actually, I never thought I'd publish the papers on the impact of that until the mid-90s, when we have seen so many obstetric problems from cocaine, including, of course, the well-known problems like abruption, like others. But we have experienced tremendously frankly, painful complications from the use of narcotics in pregnant women. So the delicate balance between the two could be, evaluated and defined. How could that be possibly evaluated? I would not go beyond what Dr. Agarwal has mentioned this morning, which is basically a tremendous development in our ability to, with Demayoxis and other methods, to evaluate basically the reductive oxidative potential in the semen analysis as well. How does reactive oxygen species affect actually infertility? We're not sure of the exact step, but there is definitely an increase in DNA fragmentation, and there is definitely a decrease in DNA fragmentation after supplementation by antioxidants. And this has been done by many, many studies. Again, Dr. Agarwal mentioned their work together with the Hamad Hospital, and we did other work extensive in Egypt that confirmed the same. But it does increase both the single and double-stranded DNA breaks, chromosomal rearrangements, DNA cross-links, deletion and frame shifts, production of base-free sites, modification of bases, and denaturation and DNA base pair oxidation. So all this could contribute to the damage that we see from basically reactive oxygen species. Are they useful in any way? Yes, they are. So because they are useful in hormone signaling, they are useful in the process of oocyte maturation, in the process of ovarian steroidogenesis, in basically in maintenance of pregnancy and blastocyst development and others. Why am I saying this and that? Because these will be the issues that we will try to define when we design a study. We'll try to design a study that focuses on one or more of those points. Folliculogenesis, we all understand that the folliculogenesis is a complicated process affected by the hormones, affected by also local autocrine factors, and by many factors in the follicular fluid. It is amazing that the amount of basically reactive oxygen species in the fluid is less than the amount in the blood, basically showing that there is something of antioxidant nature in the fluid that balances the impact of those reactive oxygen species that are present in the blood. There has been many generic studies from the 1990s that suggested that severe deficiency of certain of the antioxidants results in an increase of the reactive oxygen species, and hence deterioration in folliculogenesis. Furthermore, deterioration in the blood supply alone has been shown to be associated with poor follicular outcome. Studies from Professor Campbell, Stuart Campbell in London, have shown that the blood supply of an individual follicle is correlated with the quality of the oocytes that you can get from this particular follicle. What about the endometrium? This is an area that we have taken some interest in a few years ago to look at the endometrium and the oxidative stress. And let me just go to this simple cartoon. And this was our work together with Dr. Agarwal about 10 years ago. We published in 2014. Basically, on the right side is a situation when pregnancy happened. On the left side, the situation when pregnancy does not happen. So when pregnancy happens, there is HCG that is produced by this in situ trophoblast. That HCG increases the progesterone. The increase in the progesterone will increase the superoxide dismutase, will decrease the oxygen radical, the activating factor, will also decrease the cyclooxygenase and the PGF2 alpha, which eventually results in, be part of the menstruation, which is an increase in prostaglandin F2 alpha. On the other side, you have no pregnancy, so no HCG, the progesterone will drop, the copper zinc superoxide dismutase will be lower, the oxygen radical will increase, activating factors increase, cyclooxygenase increase, which is part of the mechanism for formation of prostaglandin F2 alpha. And when you have prostaglandin F2 alpha, what does happen? It results in menstruation. So on the right side is a pregnancy situation with an increase in HCG, progesterone, superoxide dismutase, a decrease in oxygen radical cyclooxygenase, and decrease in PGF2 alpha. And then the opposite on the left side, where you have a no HCG, so the progesterone will drop, and we all know that the progesterone drop is part of the mechanism for development of menstruation in the cycle after no pregnancy. Superoxide dismutase, oxygen radical will increase, activating factor increase, cyclooxygenase increase, and PGF2 alpha. So this is basically the endometrium. Endometriosis has been, a lot of work has been done again by the Cleveland Clinic group. Basically, it's not what you think, that the excess iron, for example, in the hematine or in the heme in the blood is the contributing factor. It really has no direct relation with that, but there is definitely an increase in non-enzymatic peroxidation and heat shock proteins in the endometriosis. And there is no question that there is excessive oxidative stress in patients with endometriosis. What about polycystic ovarian syndrome? There is also good evidence that there is an increase in mitochondrial dysfunction in women with polycystic ovaries. So polycystic ovary is, as it is a syndrome, because we have multiple follicles, but they do not achieve maturation on their own and growth on their own. With stimulation, they get stimulated, but if you give excessive stimulation, you stimulate all of them. If you drop the stimulation to a moderate amount, you get no stimulation at all. Many studies have suggested that there is a change in the quality of oocytes from the follicles of polycystic ovarian syndrome patients. This is compensated for in IVF by the presence of a large number of oocytes and hence a good number of blastocysts at the end. So this compensates for deterioration. There has been many publications, some coming from Egypt, certainly not from our group, but from other groups in Egypt, suggesting the use of myoinositol and others in women with polycystic ovarian syndrome. So again, what is the impact on infertility in general? There could be direct damage to the oocytes by lipid peroxidation and DNA damage. There could be impact on the fertilization by the different oxidative stress factors in the peritoneal fluid. We sometimes think that the fluid in the hydrosalpinx, by regurgitating back towards the uterus, could cause an increase in the embryo loss rate after IVS, and that could be through oxidative damage, because not all those patients have an active infection at the time. As a matter of fact, we all know that the majority of them do not have an active infection, but that fluid in itself is harmful, as has been shown by many studies, that interruption of the fallopian tube or its removal would result in an increase in the pregnancy rate and the live birth rate in this group of patients. So again, going back to the follicles, the good blood supply to the follicles results in a decrease of reactive oxygen species, an increase in the blood flow, and an improvement in quality of oocytes. This particularly been shown in patients with a low number of follicles, where you can correlate the individual follicle with the oocyte at the time of egg retrieval, and hence you can follow each egg on its own if you put it in a different dish. Which step is affected by oxidative stress? Is it the effect of fertilization? Is it the effect of cleavage? Is it the effect of blastocyst formation? So to design a study, you have to design a study that will determine a yes or no answer to every one of those steps if you add antioxidants. Because you cannot say that it will do everything. For example, if a patient has very low AMH, which is a marker for the quantity of oocytes that's produced, giving her antioxidants will not miraculously give her a new ovary. So you cannot assume that somebody who has an AMH of 0.0001 and you give her all the antioxidants that you have, that she will have 20 eggs like the other lady with polycystic ovaries that has an AMH of 4, for example, or 6. So you have to define what are we going to test. And I want to share with you this morning for us and this evening for you, the 2 studies that have been really, that had attracted a lot of attention in 2020. The first study basically has been an Australian study by my dear friend Dr. David Gardner on the oocytes by adding antioxidants to the culture media. And then the second has been our clinical study where we have done oral supplementation with antioxidants for 3 months prior to IVF and looked progressively or prospectively on those patients and compared them to a retrospective control of women who underwent IVF. So again, my focus will be on assisted reproductive technology, and my focus will be on laboratory steps that are affected by the addition of antioxidants or oral supplementation and its impact on a group of IVF patients that we have performed. Prior to that, there has been many studies. You have to understand that many of that literature, if you look at the left side, is from 1994 to 2003, before the development of many of the successful steps for blastocyst developments and so forth. So although the studies on the left side of the cartoon shows you supporting basically that antioxidants work very well, there are some on the opposite side that show you that it made no difference. And in animal studies, there has been also some positive effect. So I think it would be very beneficial to all of us to already look at the role of antioxidants in the modern era, which again, I will share with you our clinical study, clinical supplementation, and that's oral antioxidants 3 months prior to IVF. And then the second is David Gardner's study of adding 3 antioxidants to the culture media. So what they did, this was a multi-center study. It was a prospective randomized control comparing sibling oocytes. What's sibling oocytes? Meaning the oocytes from the same cycle from the same patient. So the primary objective was whether to see is the inclusion of 3 things: acetylcysteine, carnitine, and alpha-lipoic acid would improve day 3 embryo culture. Again, remember, these were added to the G media, to the Gardner media. So they will look at the day 3 culture and then the day 5 to 6 blastocyst quality and the clinical pregnancy rate, which is at the end of the day, all what we are after is a singleton healthy pregnancy at this point. They looked at 1,563, about 1,600 eggs, metaphase 2 oocytes from 133 patients that went through in vitro fertilization. The study group was the supplementation of the IVF and culture media with the 3 antioxidants, the carnitine, N-acetylcysteine, and alpha-lipoic acid. And the control group, same embryologists, same scientists, same everything, with the same culture media, which is the G media, but without the addition of the 3 antioxidants. When we looked at those, the design of the study was to look on good quality embryo. What does that mean? 8 to 10 cell, very low fragmentation. Good quality BB blastocyst, this is defined as 3 BB or even better. Clinical pregnancy rate is defined as the presence of a gestational sac per embryo transfer that is there. And these are the results. So the results, they looked at the left column is the Gardner series media, and the right column is the same media with 3 antioxidants. When they looked at day 3 embryos and then fetal sac, fetal heart, the day 3 embryos, there was 50% in the antioxidant group compared to 41% in the G series. And then when they looked at the gestational sac, it was 50 versus 39. And then the fetal heart, it was 47 versus 37%. Put it into bar charts, you can see the purple, and the 2 colors, the violet on the right, and then the purple on the left. You can see there is an improvement in the antioxidants group for day 3 embryos, for fetal sac, for fetal heart as well. They tried to be more defined, so they looked at patients that were basically below 35 and then patients who are 35 to 40. So this particular focus is on women between the age of 35 to 40 who are considered the older group of women. On the left side is using the Gardner media. On the right side is using the antioxidants added to the culture, to the G media. And again, we looked at how many of them had gestational sex, cardiac activity, ongoing pregnancy rate, mean pregnancy rate past the half point of the pregnancy. So when we looked at the gestational sac, there was a significant improvement from 23% to 57.5%, very significant improvement. When we look at the cardiac activity, again, 23% versus 50%. When we look at the ongoing pregnancy rate, 25.8% versus 50%. So what we're looking at here is, if I bring you back to the total group of patients, including the below 35 and above 35, there was an improvement definitely in all those criteria. You know, again, gestational sac and cardiac activity are improved. But when we look at them only in the women who are 35 to 40, you see a tremendous improvement in the pregnancy rate in those group of women, basically from 23.5. So again, the idea that the conclusion that it is possible that in women who are older, between 35 and 40, that those women undergo more oxidative stress, and hence the addition of antioxidants to the culture media was even more significant than the younger group of women. And again, putting it into cartoon where the bar charts are very clear, you look at almost doubling each of the three parameters that we look at, which is the gestational sac, cardiac activity, and ongoing pregnancy rate. The conclusion: the presence of antioxidants during IVF and embryo culture for women who are 35 to 40 resulted in a significant increase in implantation and pregnancy rate. And therefore, supplementation of antioxidants to the IVF and to the culture medium may therefore improve the viability of human embryos in assisted reproductive technology, possibly through the reduction of oxidative stress. So this was published by the Australian group in May this year in Reproductive Biomedicine Online by David Gardner, the lead author in this study. We just looked at our results for the clinical study that we have done, and that study looked specifically at oral supplementation with antioxidants. We used FH Pro, that was referred to earlier by Dr. Agarwal, made by Fairhaven Health in Washington State. We did have two groups of patients. The first group of patients is a prospective group of patients from October 2018, basically till the present time. The study is just being concluded, and the analysis is from October 18 till July 2020. And the control group is the group of patients that underwent IVF at our laboratory in the 18-month prior to that. So there has been no change in the scientific staff, no change in my embryology team, no change in any factor other than the addition of antioxidants for 90 days or more prior to the IVF. What did we look at? We looked at the clinical pregnancy rate, blastocyst formation rate, and fertilization rate. So these are the three things that we looked at. And again, a prospective group of patients versus a retrospective historical group. So the prospective study was basically consecutive IVF patients. We offered to all the patients that are coming from October 2018 onwards, where they were all supplemented. The data was compared to a similar cohort of patients who underwent IVF in the preceding 18 months. We call those the historical group of patients. The patients were between the age of 20 and 40. They were, of course, be able to understand the study and to participate in it. And we followed with them closely whether they are adhering to all the instructions and criteria. They agreed to basically complete all aspects of the study. We included both, every ethnic group. This study was done in our center in Texas, and there was lots of patients of Latino origin in this group, but we included Caucasian, we included African American, Black population, we included Latinos. We did not exclude any group from this study. But we excluded any patients who've had a history of cancer because it's possible impact on the oxidative stress. Anybody that had a major surgery in the past 30 days prior to the initiation of the study was excluded. If they had significant trauma, like car accident, anything serious like that in the previous 3 months, were also taken out. Also, if they had chronic GI conditions like irritable bowel syndrome or something like that, that would also be excluded from the study. If the patient on her own was taking other antioxidants, and there are lots in the over the counter, so if they were taking an N-acetylcysteine, selenium, zinc, copper, and so on, separate from the FH-Pro that we have used to give them, that was specifically and specified in amount and quantity by Fairhaven Health, that was, they were excluded from this study. During those basically 2-year periods, we had 384 patients that were screened from for IVF, screened from that period starting on October 1st, 2018 till now. Now we're November 1st, so we're done. 124 patients were interested in the study. We collected their first demographic criteria, reviewed all the medical history to see if there is any history of, again, chronic inflammatory condition or cancer to be excluded. And we reviewed that with them. Basically, 76 of those patients met all our criteria, the eligibility criteria, and were offered the drug. And at the end, we had 52 patients that went through it, and we controlled them with another 52 patients. So we had total of 104 IVF patients in the study. They were all between the age of 20 and 40. And as I mentioned, we have totally excluded all those patients who have been on other supplementation, who have been excessive amounts of acetaminophen, who have experienced trauma, and so forth. The analysis was done on the patients who have completed the study, completed because the patients go through fresh IVF, and then they actually, that was historically the case, and then we moved to freeze all embryos and single blastocyst transfer, meaning that the patients, as you all know, go through IVF, we freeze the blastocyst, we do not put them back, and then we, when she decides to put them back 1, 2, 3 months later, we put them back. So a patient would be completed, of course, if she had all those steps done. And if she, for example, was doing embryo banking just for the future, then she would not be possible to analyze that. It's also if, for example, if she is doing egg freezing, she's concerned about her future fertility, then it would not be possible to analyze that. So the study group that have completed the removal of oocytes and the transfer, there were 33 in each group in the prospective and 33 in the control. The fertilization group was slightly higher, but did not reach statistical significance. It was 64% versus 57%. The blastocyst formation rate was also higher. But the clinical pregnancy rate was highly significant, was 67% versus 36% clinical pregnancy rate in the prospective group compared to the historical group. Was the only factor that has been modified has been the recipient of antioxidants for 3 months or more at the time of the study. When we put it in bar charts, you look at the blue side, which is actually the supplementation group or the study group. The control group is the retrospective group. So there is an improvement in fertilization that was not statistically significant, and an improvement in pregnancy rate that was statistically significant, with almost doubling of the pregnancy rate in this group of patients at the time. We conclude from that again, we cannot evaluate steps that are not part of the study. For example, your response. This was not something that we were interested in, because we know that response is affected by many things, including dose of medicine, include the number of follicles at the beginning. So if you take a patient that has 2 follicles and a patient that has 8 follicles, there is no antioxidants in the world that would make the 2 follicles become 8 follicles, or vice versa. But we looked at the basically the clinical pregnancy rate, implying that this is a reflection of also the quality of the blastocyst, which could not be assessed because PGT was not done part of that. And even if PGT was done, it is reflective of a very narrow area of the study. There was a significant improvement in the clinical pregnancy rate of approximately basically doubling the pregnancy rate from 36% to more than 66, actually 68% in all the study. We're going to analyze it depending on the age groups in this group of patients. But the evidence from our clinical study and the evidence also from the lab study, although they have different approaches to the same problem, the problem suggested that women undergoing through ART undergo oxidative stress, particularly that incubation in incubators, all these strenuous things that the embryos are exposed to is much more than actually happens in natural pregnancy. So the addition of antioxidants might possibly reduce some, if not all, of this damage. The addition in the lab situation and the oral supplementation have both been in agreement. We hope that more randomized controlled trials would be available to elucidate the 2 points that we have made, to show you the complexity of it. I mean, it took multi-IVF centers in Australia to come up with 133 patients. So, and every one of those centers are doing thousands or more. But by the time you lose a group of patients through everything in the study, it takes a lot of effort to do that, and therefore it might be that the prospective randomized trials will need again a multi-center in this. If you want to achieve a number like 300 IVF patients in each arm of 400, but at the level that we have concluded so far, based on our first 50 patients and based on the 33 that have completed, we have demonstrated an improvement in pregnancy rate that is encouraging to do a prospective randomized controlled trial at this point in time. And this again has been confirmed by the IVF lab supplementation, which is a very different approach, but same concept to be tested. And again, I want to thank you for this wonderful opportunity to share some of our thoughts with you. I hope this stimulates you, and perhaps in some of your beautiful and large centers in India, you can be part of these studies. And this is one goal that we have from our international meetings, is to get international collaboration. I think it would be tremendously beneficial to our patients in the long run. And thank you again, Dr. Sunil. Thank you, Dr. Agarwal, for your kind invitation to me to be part of your very prestigious platform. Thank you.
Thank you, Dr. Peter. It has been phenomenal. Thank you so much for the lovely presentation, and of course, the conversation before that, which was extremely stimulating. I would now like to invite Mr. D.P. Satpathy, who is the Vice President of Intas Company, and he is the Vice President of the Women's Division of Intas, and he has been associated with this business for over 2 decades, and he has launched a lot of wonderful products. And this scientific meeting has been taken care of, and the main participant has been Intas Company. And Mr. D.P. Satpathy was kind enough to put it on, and with Dr. Ashok Agarwal and Dr. Peter, to make it into a certification program. Now, I'll tell you about how the certificate would be sent to you. And I will also tell you of Dr. Agarwal has been extremely kind of gifting to everybody who fills the AOX survey. I'll just tell you about it. And with the certificate, to gift a free ebook on antioxidants by Springer. But before that, I would request Mr. Satpathy to please say a few words, and he also has to launch an amazing product, which we all have been waiting for. So, Mr. Satpathy, please.
Thank you, Dr. Jindal. Thank you, Dr. Botras and Dr. Agarwal, for such a wonderful discussion. I think the myths about nutraceutical in our mind would have lasted forever if we would not have attended this webinar. Other than science, it was wonderful to know about your life, your beliefs, and I must say that you are true inspiration for all of us. At Intas, we always believe in bringing you products backed by science and benefits as it claims. Today is one more such wonderful day where we are offering you a new product. And for this, I would like to request Dr. Jindal, Dr. Botras, and Dr. Ashok Agarwal to join me for unveiling the product. The brand is Ciocetal, the complete formula for obese and lean PCOS. So I would request the AV team to launch the product, please. I think there is some technical glitch, and Dr. Jindal, I would request we can move on to the question answer session, and maybe we can play the AV clip at the end. Is it ready? Okay, we can move on to the question answer session, please.
Yeah, I think there is some technical issue. So this could be probably, it's been launched, but it'll be relaunched in the end as well after this. So I think what we should do now is, before the question answer session, I would bring forth to you the way Cleveland Clinic and Dr. Agarwal and Dr. Botros have planned it. This program, which has been there on antioxidants, this would be complete once all of us fill in an antioxidant survey. It's a worldwide survey, which is going to be very useful for antioxidant therapy in the future. So once the AOX survey has been filled, then we would be able to send you the certificate, because the program would be completed, and the certificate is going to be of the online masterclass, number one. And also, Dr. Agarwal has been able to gift all of us a publisher released ebook, which normally costs about 54 euros free. Thank you, Dr. Agarwal. Thank you so much. So
Right. Initially, we thought of like we had a go ahead for giving 300 books for the first 300 registrations, but later on, Dr. Agarwal was kind enough to gift it to all the participants who have joined, I think, which is around 1500 plus. What's the number, Viyat? Okay, so I think.
okay, anyway, so the method of that would be that we have your emails, and we would be emailing you a link. That link would have to be taken and filled. Once it is filled, we will immediately send you your certificate as well as your book. Another way of doing it would be, which probably would be simpler, would be, I'll just, you could save this number, 800 6666 004. I would repeat again, 800 6666 004. Please save this number. Once you have saved this, please send your contact name to this number. So on WhatsApp, we will send you the link, and once you have filled it, your certificates would reach you, which is the free ebook as well as the certificate. So please fill in this number. Somehow in the chat box of the participants, we have not been able to place it. So we have this slide over here. Please, I would repeat again the number, 800 6666 004. So just save this number and send your contact, please, so that we could do this further on in the process. So this has been great. Now the question answer session. Now, Dr. Peter and Dr. Agarwal, we have received about 34 questions. Now, and I mean 34 bunches of questions. They're different questions, but together they would make 34 questions. So it would really be a pleasure for me to ask you one by one, which means one question from Dr. Peter and one question from Dr. Agarwal. So the first question which I would like to ask, I'd like to ask Dr. Peter is, I've received a question which is, which micronutrient intervention you advise to support implantation?
That's a great question. And if you look carefully at some of the details that I didn't list on the PowerPoints because they're just overviews, is that when we used the FH Pro from Fairhaven, there was a difference between the antioxidants used for the male from the female. So, for example, the amount of carnitine that is used is very different, the amount, and so forth. So we have classically used the three antioxidants: acetylcysteine, carnitine, and alpha-lipoic acid. And these have been the classic three that have been used in both our oral supplementation as well as in the IVF lab data that has been used. Of course, and I would like to stop there and wait for Dr. Agarwal to see what he thinks about the male side. But these three have been used consistently in almost all the studies on the female cause of infertility resulting in assisted reproductive technology. And again, I'll see what Dr. Agarwal says on the male side. The second point is that I've alluded to that although that there have been several studies from Egypt, for example, that suggested the use of other elements that we have not used in this particular study, particularly, for example, the PCOS patients using myo-inositol and so forth. But I'm very interested to see what does Dr. Agarwal use for the male infertility side of his two major clinical trials that he has completed and published.
Great. I have a question which is a similar question because I've tried to take the questions similarly. And the question is to Dr. Agarwal, which micronutrients will you start for a patient who is going to undergo an IVF for the male partner? Will you start it in all or will you start it in particular indications?
As I mentioned in my study, the dichotomy, the controversy, which is there in terms of the efficacy of antioxidants is because these antioxidants have been given without any kind of testing to indicate whether the patient really has a basis in which the antioxidant will be able to mitigate the problem. So I will first, giving the antioxidants, look at the underlying reasons. And if the testing is available and it is easy to conduct, that will be the first thing that will be done to measure the oxidative stress, which is really, I believe, is the most important aspect of correctly diagnosing and then prescribing the antioxidant, because that's where we saw the highest level of efficacy in patients who had male oxidative stress infertility. So, however, if, for example, if the patient is undergoing IVF for reasons such as where they have very high levels of sperm DNA fragmentation, or a condition where they had previous failures, I believe in those patients, there is a cocktail of antioxidants, which is what we have in our study, which we published with FH Pro, but also it is the common thread in most of the other products that we see, things like L-carnitine, and N-acetylcysteine, coenzyme Q10, vitamin E, vitamin C, zinc, selenium, folic acid. These are some of the common ingredients because we know from the studies that have been done, they demonstrate that vitamin E or C is really helpful in improving the concentration, while the motility or aspects of motility are improved by a combination of L and acetyl carnitine in correct dosages. And then we have N-acetylcysteine, which really can improve on the DNA damage. So looking at the particular ingredients, you can relate it to the etiology that the patient has and then match it to make sure that the results will be really beneficial and the patient will benefit from these antioxidants.
Fantastic. So you would recommend different drugs for different parameters of the semen, which means
no, this is actually the strategy that will be easier is to find a combination products, and many of the manufacturing is being done with that aim, that many of the companies are actually manufacturing it where they have all the different ingredients in one proper dosage. Um, and it's very difficult to isolate a single defect that may be responsible for failure in ART. If that is very, very clear that the clinic can really establish that this is the only problem that they have, then maybe a single antioxidant could also be helpful, but it has to be targeted and matched with the actual abnormality that they are experiencing, which is leading to poor outcome in the ART.
Is the dose very important?
Dose is extremely important. And as I showed in one of my tables, the dose is the most important determining factor. Three things which are most important: making sure that the dose is correct. It is the daily recommended dose. You don't want to go above that because there could be harmful effects of excessive antioxidants. Second is the duration of treatment. You really have to treat the patient for a minimum of 3 months or 4 months or up to 6 months, because that is based on at least 2 cycles, full cycles of spermatogenesis. And the third is proper patient selection. The patients who actually will benefit should be carefully selected. So if a patient which really has no underlying etiology that will really help with giving the antioxidant, then it's just a waste of time. And as you said in the beginning, it's just like a placebo. It's not going to do any good. It's just going to take some money away from the patient. So very important that the proper patient selection. And the fourth, which probably is not commonly available in India, but very soon it will be, is to do that proper testing. Of course, the testing that we are doing currently using the oxidation reduction potential by Mioxis may not be available, but there may be other techniques which are available in India that can be used to really diagnose if oxidative stress is one of the central etiology in these patients.
Right. Dr. Peter, there's a question, and it's a series of questions. There are about 10 questions I have received, but these questions are linked together. So I'll just ask you. It's another thing which they've asked: is the dose of importance in female infertility nutraceuticals? What is the role of myo-inositol in obese PCOS patients? And what is the role of vitamin D?
Excellent questions. So again, in full agreement with Dr. Agarwal, the dose, of course, makes a huge difference. For example, even other than the antioxidants, if you look at vitamin C, I mean, are you going to give 100 milligram or 1,000 milligram of vitamin C? So it makes all the difference. So there was a tremendous focus on 2 things. The dosages in oral supplementation should be ones that eventually result in our assessment in a way that could be verified by either the serum or the follicular fluid. And this is our next step of assessment. So for example, Dr. Agarwal mentioned the Mioxis on the male side. We try to do the Mioxis on the follicular fluid and so on. It is not as easy, of course, because for obvious reasons. So similarly, the dose impact will be determined 2 ways. The simple clinical way that you, for example, do a straightforward comparison. The second way is your expectation based on absorption, metabolism, etc., of the levels different place. Myo-inositol, your question is of great interest, particularly in view of the recent literature from many parts. I was looking recently at one of the studies from Cairo, from Egypt, on the use of myo-inositol, and doses of 2 grams were used in those studies as the starting dose for there. The third question is it affected by BMI or not, like you mentioned, the obese PCO? Absolutely yes. And we see that even on other parameters. Like, I mean, we talk about dose of fertility medicine that stimulates. There is no question that obese patients have a lower response to slim patients, not because anything for obesity, is simply that it's one of two things: either that the drug gets distributed over a larger amount of tissues. That's number one. And number two is that, is it possible that the fat in itself is inflammatory in nature? And this was a concept that we never accepted in the past. But for example, the COVID is suggesting that older patients that have a higher BMI do worse. Not because I used to think at the beginning that this is related to their ICU management and ventilation. Nothing to that whatsoever. It's simply because the fatty tissue has an inflammation reaction that is higher, and it seems that those who have high inflammation, for example, in the COVID situation, do much worse. So the amount of subcutaneous fat and visceral fat affects it so much. And of course, the best way would be to lose the fat, to exercise. But in the absence of that, supplementation could be beneficial. Thank you.
Oh, wow. Thank you so much. Dr. Agarwal, there's so many questions, but they're so interesting. The question is from Dr. Bharti Patil. It is the dose of L-carnitine 1 gram in the male?
That is correct. I think that is the desirable dose of L-carnitine. So many of the products which have, for example, 100 milligram or 200 milligram, really are not going to be very effective, because carnitine, both LEVO and acetyl, are very important, has been shown in numerous studies, double-blind placebo-controlled studies, many from Italian investigators, to really responsible for total motility as well as progressive motility improvements. So the concentrations that have been used, and this is the daily dose that is considered as recommended, is anywhere between 500 to 1,000. So 1,000 milligram is considered as a very good dose.
Thank you so much, Dr. Agarwal. Dr. Riz, there is a question which is a series of 3 questions. I don't know why people are asking you 3 questions together. But anyway, that's the way it is. Now, I'll just summarize them. It is presence of certain vaginal bacteria associated with success to become pregnant after IVF treatment? 1. Number 2, does vaginal microbiome profiling enable stratification of the chances of becoming pregnant prior to IVF treatment? The third is, what in your opinion is there on colonizing of the transfer catheter with lactobacilli species at the times of IVF ET to increase the rate of implantation and live birth rate? And along with that, the whole story is that which nutraceutical or vaginal treatment would be best if given for IVF?
Yes. So in a straightforward answer, the impact of bacteria on the implantation, I believe, is true. And I could confirm that to you clinically at 3 levels. Again, the group of women who have hydrosalpinges have a lower pregnancy rate, despite that the embryos are equivalent or the same, because of the fluid in the hydrosalpinx possibly has infection and possibly has high inflammation markers as well, and that comes through. And again, both the removal of the tubes and interruption has an impact. Second, on the endometrium itself, so that's the tube. Second, on the endometrium itself, chronic endometritis has been associated with lower implantation rate, no question about that. Third is the lower part basically, or upper vaginal, like vagina and cervix and so. There is definitely the increase in infection has an impact. There has been not many, but there has been a handful of studies where actually the transfer catheter taken some of those bacteria up, and then the tip was cut and then cultured after that, and they showed an inverse proportion between the implantation rate and the pregnancy rate in those group of women. And I do believe in all of them, to the point that many IVF programs use something like doxycycline routinely for anywhere from 2 to 10 days in our IVF patients and so forth, because even in patients who apparently has no hydrosalpingosis, has no chronic endometritis, and also has no clinical criteria for upper vaginal tract infection, do have an infection. To manipulate it using supplements is more difficult to ascertain. It's not say that it doesn't happen. It is just more difficult to say what do you manipulate it with and what does it result in terms of a higher pregnancy rate. I think that would be definitely a kind of a question for the future to determine.
Thank you. Dr. Agarwal, there's a question. In case the patient has seminal infection, and in a patient like this, along with antibiotics, will you give nutraceuticals or will you not give nutraceuticals?
So the basis for giving or not giving in cases of pus cell or leukocytospermia, if there is an infection such as prostatitis, urethritis, will be in case we see that in addition to having the infection, that the patient also has a high oxidative stress in their semen. If we are able to test that and tell that the patient has a high ORP level, for example, this is what we do, which is the oxidation reduction potential, then both the antibiotics as well as antioxidant will be legitimate treatment of choice. So I think this will be dependent on, before we start giving antioxidant, I think there has to be a proper reason for giving it. This is my firm belief, because I believe that so many studies which come in the literature and show that there is no advantage of giving the antioxidants are being done with the wrong premise. And I think if we can really think it clearly and go through and see what may be the reason for giving the antioxidant, and if we can have that very clear, then I think it will be reasonable to ask the patient to go for the antibiotic and with the antioxidant that will help clear up the infection as well as improve the semen quality later on.
Dr. Ritz, there is a question asked by Dr. Huda Omran. What is the role of vitamin D in IVF?
That is an open-ended question. There are simply extreme studies that suggested that significant deficiency of vitamin D could have an inverse proportion to success. But to say what is the exact role of vitamin D is more difficult than to say that vitamin D has an impact. Like at what stage? We know that calcium plays a tremendous role, as we're all very familiar, even in men who are taking calcium channel blockers, their ability of the fertilizing ability of the sperms is reduced. But is the calcium role just limited to that, or no? Is possibly related to other factors as well. So yes, extreme deficiency of vitamin D has been shown to be inversely proportional to success. But does different gradients result in different outcomes? I don't know. And does actually supplementation in what amount also, we don't know. Like there is vitamin D in the supplements that we have used. But we have seen in a very similar but different field, completely different, like osteoporosis, recommendations that range from 400 units to 2,000 units based on the three societies that make the American recommendation: American Society of Osteoporosis, American Endocrine, and so forth. So maybe that's a topic for future research between us.
Yeah. There's a beautiful question which has been asked. And the question by Dr. Tulsi is, what are the antioxidants or nutraceuticals which you use as a routine in IVF patients?
For me, currently, I routinely use FH Pro for all IVF patients. Because as you know, particularly in the US, IVF is very involved process. So to every aspect has to be optimized from the beginning, completely. I mean, a total IVF cycle, as you know, is very involved psychologically, very involved medically, very costly in the US, somewhere, in the, very, very, very high cost. So to deprive the patient of one aspect that might be influential it could be a mistake. So, for example, we ask them not just the antioxidants. We ask them to, decrease their smoking. If they can stop, by all means, stop. Decrease their drinking. If they can stop, by all means, stop. Exercise, if they can do 20 minutes a day, that's great. If they can do 10, that is okay. If they can do more, that is better. Can they use antioxidants? We recommend them to use antioxidants. And we have been using basically FH Pro for the past 3 years.
What does it contain, the FH Pro?
Basically, beside the usual A, B, C, D, we also contains the acetylcysteine, carnitine, alpha lipoic acid, selenium, zinc, Yeah.
Now, Dr. Agarwal, there's a question. Why conventional semen analysis is not an adequate surrogate marker or measure of male fecundity?
That's a very important question. In light of the guidelines and standardization from the World Health Organization, which is responsible for standardizing the assessment of semen sample by publishing standardized guidelines starting from 1980, when the first guideline was published, all the way to 2010, when the fifth or current guideline was published, called fifth edition. And the reason, Sunil, is that semen analysis is really a very, very difficult test to standardize and to learn and to conduct correctly. Although manual semen analysis by default is considered as the gold standard, but it really is a rotten standard because there is no standard. So by default, we have a test which was more like developed in the stages of Bullock cart when 100 years ago, but it has really not been able to change very much, just because the test itself requires someone who is really very active, very smart, and is able to count moving cells which are moving at all different speed and be able to tell which is motile, which is normal, which is abnormal, look at hundreds of shapes and be able to tell which one is really meets the strict criteria of 4%. So there are so many barriers which makes it very difficult for a test to be taught, to be trained, and the results of the test are a disaster. 97% of the labs which conduct a semen analysis really do it incorrectly. And this is the hard data. And I think because of these reasons, at least in the United States, this test is considered as a high complexity test, and it is regulated by the government. So the real advances that have started happening over the last 30, 40 years is with the development of devices such as computer-assisted semen analyzer. And these devices, the goal of these devices is to really standardize the procedures, automate the system of doing the analysis, reduce the inter and intra-observer differences, and make the process much more predictable and easy to conduct. But it hasn't been very successful. These devices are very expensive, just like you go and try to buy a Mercedes. Some of the devices like could be $40,000, $50,000, $60,000. And at the end of the day, they still require huge amount of human intervention. So they are not completely automated by any means. So whether you are talking about the companies such as Hamilton Thorne or Microptic or other They are all making these high-end devices, but they are really require a high-end person to work with them and run the machine. So they have to be trained. There is a lot of work that is required. In the last 1 or 2 years, a new company which has come out with a really smart artificial intelligence driven device, which is called Lensook. And Lensook is a system which we have validated, conducted clinical trial. It's approved by the FDA and CE mark in Europe. Provides excellent results, very high degree of correlation, and very high degree of reproducibility, completely automated, and does the semen analysis in 5 minutes, as opposed to a routine semen analysis, which can take at least 2 hours to conduct. And still you will not have the results on the same day. But here you have the results in 5 minutes while the patient is waiting, and Dr. Risk or you can really talk to the patient and tell, listen, these are the problems and we have to do this, is this. So I think that's the future. I believe that the technology is going to drive the market in every field. And I think this is already happening in the area of assisted reproduction. We have a lot of things that are happening in IVF, and now in andrology, this is one step. There are many, there is a lot of room for improvement in this technology, and I'm sure this will be happening. But I believe that this is the biggest advances in the field in the last 100 years. And I believe that many more advances like this will be what will drive this entire process in the coming days.
Fantastic. Now, the last question I'll ask from Dr. Ritz, and the question is, how do you measure oxidation potential in female infertility?
Well, that has been the subject of 2 PhD students that we had, and it's of course much more challenging. So what we started when Dr. Agarwal started with working on, say, the Meioxis system on the male. So we took it in one of the large centers actually in Cairo, and we just Center for Male Fertility, and we applied it, and we really got very straightforward, very good results, and we showed that supplementation made a difference. So we did before and after. Then we came to the female. We were challenged, what are we going to measure it on? I mean, what exactly can you measure it on? I mean, the egg, of course, is not accessible to us until it is time for the IVF. So we decided, during one of the studies, to use the follicular fluid as measurement, and there were significant challenges with that we have not overcome all of them. But the target would be to modify either the test or modify the way we do it so that we can apply to the follicular fluid. Then you come into another problem, is that the follicular fluid, will all the follicles be the same? Will it be an average of all the follicles? What if some of the follicles had more bleeding than the others? So these are the challenges we have. Like there would be a very clean follicular fluid from one follicle, and then 2 follicles down, just putting the needle again would cause a little bit more bleeding. So does this affect it? And then is it fair enough to say, okay, I'll take 5 follicles and average them or not? But this has been our focus. We had actually one of the we had two PhD students working with me in collaboration between the University of Cairo and Alabama to do that work, and we're still facing lots of problems.
Fantastic. Thank you very much. It has been such a pleasure to have this amazing program on something like nutraceuticals. I mean, which nobody really thinks about, but probably in the future, this is going to be the future. I would request Mr. Satpathy to please join in, and please let us know something which you would like to share with us.
Thank you very much, Dr. Jindal. I think there could not have been a better program than this on nutraceuticals. Believe me, in my last 20 years experience in the women health business, I haven't seen a program with so much of evidence and so much of information on nutraceuticals. we were always in ambiguity in the market. We used to face, I'm sure all the audience who have logged in would agree with that. There were two school of thoughts. One school would say that nutraceuticals are useless, and the other school would say that yes, it does work. So the amount of clarity which you have brought today into the subject, I'm sure it is going to be helpful for all the people who have joined in, and probably these people would percolate this message down the line to their colleagues and friends. Going forward, I would look forward to your help for conducting more programs, because India is a vast country and we have 30,000 gynecologists, and we have just a chunk of 2,000 doctors today in this webinar. So I'm yet to take this message to the other 28,000 who have not yet attended, because on and off, every gynecologist in this country does use some amount of nutraceutical, empirically or with some logic or with some evidence, or out of his or her practice. So we being a company, we would be absolutely in the focus in bringing in knowledge and new scientific advancement to the fertility, and we would always look forward for your support. Dr. Ashok, you have been always being supportive to us, and we consider you to be one of our family member. So thank you very much. And Dr. Botros, you are a wonderful human being, other than being a doctor, successful doctor, I would say. So it was nice being associated with you, and we would love to be associated with you in future also. Thank you very much. And Dr. Jindal, as usual, you were wonderful. And I always used to tell in all the webinars that you are in a wrong profession. You should not have been a doctor. You would have been a good anchor, rather in a probably in national news or something, and making many more leaders than being a doctor. So thank you very much. Thank you.
And Mr. Satpathy, you were not able to play your launching video.
Yeah,
There was some.
We are ready now.
And
Yes,
just tell us
sir.
something about the product which you are launching. What is it exactly?
Yeah, can you play the video, please? I think it still has got some problem. Can you make the audio full, please?
Maybe it can be sent to Dr. Sunil to play.
No, I think we've got
There
sometimes
is some technical problem.
Yeah.
there's some technical problem, but let me tell you one thing, Mr. Satpathy. Sometimes the Charlie Chaplin movies without sound are brilliant. So I really feel it's brilliant. We've understood of a product which has myo-inositol in a dose of 2 grams. I have normally seen about 500, 550 grams in the country, and with vitamin D. So it's nice that that area of supplementation is being covered, which is great. And thank you, Dr. Agarwal, for being here as a friend and as a brother. And Dr. Botros, I will thank Dr. Agarwal for introducing you to us. And we would keep in touch, and we would need your support so many times in this country. Thank you very much.
It was a great pleasure. It's an honor. Thank you.
And probably once the travel restrictions are off, probably you coming to India and speaking to these doctors directly.
I really look forward to that. I really look forward very much. Thank you.
So much, sir, and have a great day.
Thank you.
Thank you.
Thank you very much, Sunil, for an excellent program. I think you really ran a beautiful program. I think it went extremely well, and the questions were very well asked, and it was really managed very well. So thank you very much. And Peter, you did a great job, which was not something of a surprise. I've seen you with this on multiple occasions. So you really did a great job. Thank you very much for getting up so early and
Opportunity.
jumping into it right away. And Satpati ji, I think wonderful program, very well managed, and all your team has been very helpful. So good luck and success in your ventures. Thank you for involving us, and we are very, very happy that we could come and join you. Thank you.
Thank you,
Thank
Dr. Agarwal. Again, thank you. It's a great honor.
Bye-bye.
Thanks again.
Thank you.
Bye-bye.
Haji
Can we
sir.
stop now?